expanded, in fact, globally to have this course. The main highlights of today's course is to have you all have a hands-on session on the robotic systems. Apart from robotics, you have normal knee-bone, sawbone sessions which you can do, see the instruments. So I welcome you all to the 4th ANUP Masters course. The program agenda, the small program agenda has been distributed to one and all, but what I recommend for one and all is to please kindly download our app AMC 2022 from the Google Play Store or the App Store, Apple App Store. And it's all lively being fed. The program, in case you miss, you have to attend anything, or as we are doctors, we might have emergencies at any point of time. You can see the live TV on the app. You can also see it on the AMC YouTube. You can see it on the Ortho TV, and it is also on the Facebook Live of ANUP Institute of Orthopedic and Rehabilitation. So we have tried to reach all the places so that everybody can see, even if they can't come. So before I take you downstairs, I'll just go through the brief outline of the workshop basics, and then we'll go downstairs. Can we have the PowerPoint, please? From start.
This one, I think, sir.
No, sir,
hold on a second, sir. This one is yours?
Yes, sir.
Here it is, sir.
Yeah. So, fine. Now, one thing, first I would like to make it clear. Now, everybody, let's talk about knee. When we talk of, I did a TKR, we all say that I did a Stryker TKR, I did a Zimmer TKR, I did a Merrill TKR or a Sharma TKR. But how many of us say that I have done a single radius knee or a multiple radii knee? So that's the concept which we should have. So when we are talking, we should have that what is the output? Are we doing a CR knee, cruciate retaining? In the same way, the robot. So I'm talking about the Mako robot, which you will be seeing downstairs. It is an enforced controlled robot. So it is an enforced controlled robot, because in the market you have other few systems and they are fully automated bird-based robot. But the good thing about this is enforced control robot. Your hand will be guided where you have to cut. It is very fast, and you'll see how it works here and in the live surgeries. Now, what we aim in arthroplasty is always accuracy, confidence and reproducibility, and a flexibility. Accuracy is the most important thing, because in the long run, if you are accurate, you can always say that the implant longevity would be 20 years, 15 years, as per the patient's activities and his status. Now, total hip replacement, a simple answer in degenerative diseases, and Mako is the next level. So Mako is an enforced controlled robot. Now, when we talk of conventional total hip knee replacements, the navigation was the first part when things were improved, and it was the first stage of advancement. Then that was the computer-assisted total hip replacement. That is the latest advancement. And it is very important for all of us to adopt to the tradition, new tradition, because we should make sure that we use technology and be accurate. But it is very important to keep your old friends. Excuse me. I am saying keep your old friends, because old friends are gold, and this has been rightly said that those are silver but these are gold. So when everything fails, in hip replacement, cemented THR is always helpful. In knee, you have to shift back to manual, and I'll show you in my cases tomorrow that how we jumble between technology. So in more than 300,000 surgeries are done, and it has dramatically reduced disability, and total hip and knee replacements allows the patient to start activities which they enjoy. We give them a pain-free life. And when we talk of modern joint replacement, we mobilize the patient in 4 to 6 hours. We have less pain during the surgeries, and patients go within 72 hours, maximum 5 days. As per their station, they do it. Obviously, automation and technology continues to be a boom, and we should understand where it can be helpful. So I would be focusing on total hip replacement. Tomorrow, Dr. Adarsh will focus on total knee replacements. So problems, dislocation, leg length discrepancy, impingement, early loosening, polythene wear, and all these leads to malposition. We all know about this. So when we talk of aims in arthroplasty, we talk about component fixation, bearing surfaces, leg length, offset, all these things. But if you analyze it in a much greater way, you will see that there are some surgeon choices and there are some things which you don't know. And the very best example is leg length discrepancy, which we actually cannot judge in lateral position. In supine DA approach, it can be well judged. COR, we are not able to judge because none of us are planning here. So these are the things which we can improvise on. Of course, you can buy the best component, do anything, and the components will settle if you put it rightly. So complications where we can be better, as I mentioned, dislocation, leg length discrepancy, component fixation, and pain, impingement, bursitis, all these things. So computers and machines are more precise than human eyes. And yes, because we are in a robotic era. Now, what we can achieve, what we cannot. Leg length, yes, we can achieve with conventional, but more precisely in robotic, anti-version, retroversion, combined offset. We have so much insight over the theater that we are just right on target. Now let's talk of target, as I told you. Now this is one of the papers which shows that somehow when we are doing conventional hips, we are not within the Calaman and the Lunic safe zones. This is a paper published in JOA, and when we are with the robot, we are dead right on center where we plan. So to understand all this, we need to understand the workflow of THA. Now this lecture would help you when you go down to understand what I told you now, and again I'll be giving you answers what you need. So basically, when you'll go down, you'll see that on you have the main design overview of the robotic platform. This is the machine which we use. This is the console which actually we can see on the right or the left hand side, depending on the side of the patient. And this is what the product specialist have. So we have 2 screens and 1 system. Now, how does it work? Now, I always explain to my juniors and my colleagues that in childhood, we used to play a small paper game. If you join 100 dots, you will find a home. So we used to have it in the papers in Twinkle magazine, and every month we used to put 1, 2, 3, 4, and then you have a house or a boat. So first you have to give data to the computer. So that is known as registration. So registration is very important, and it is a common saying, garbage in is garbage out. If you don't register giving time, you will have a bad hip or knee replacement. Second is patient-specific planning, and the third is the bone preparation. So once we register the bone model, that is calculated in the accuracy level of 0.05 mm in the Mako system, and then the bone is prepared according to that. So let us say, for example, I'll show you in the live surgery or downstairs, we register the bone, and that is matched with the patient's own CT scan, and that has to be perfect in the range of 0.5 mm. So you cannot be wrong there. And then what you have planned, you take it from there. So we plan so many things. We plan and broach the femoral stem, combined version, intra-op cup planning, robotic cup placement. Now when we are doing a hip replacement, patient is in lateral, the patient is drooping forward, we don't know, the patient is obese, how much we are medializing, we don't have any clue. This is all planned. If you expose it well, the rimmer will go at once and just get your cups rimming exactly at the position where you want. And obviously the cup will get seated where it is rimmed. So we get all these values which I was showing you earlier on the screen. You can change it. Let us say you think it is, you need a high offset. Okay, let us change from 127 degrees to 132 degrees. You see, okay, no, we'll increase the cup one size more. Okay, we'll lateralize the cup one size more. So I and we are talking in millimeters to give you a perfect joint so that you are absolutely pain-free, both in hip and knee and unicompartmental. Another problem is that how much cut you should take. Now, over the time, what I have learned, one of my very senior professor, Jonathan Howell, he's the designer of Striker Triathlon. When I asked him this question, I think in 2009, he told me that you place your thumb over the lesser trochanter, and my thumb over the time has become exactly the size of what you need to cut. So he was joking, but we have a confusion how much you need to cut. So that actually you can template and plan, and nowadays you can do it on OrthoView templating softwares, but on this system we do it on a CT scan. So that's very good. Now cup positioning. You know that the cup has to be seated on the teardrop, but we can medialize 5 mm, 10 mm superior, inferior to the terms of 1 mm, 2 mm when we are doing a hip replacement. Calculate the antiversion and take it from there. We can see the cup placement on all the 3 sections of the CT scans, coronal, axial, sagittal, whatever you want, you can rotate it, do anything. So we'll shift down fast because you will be able to see how much we can get from the robot. I told you about a neck planning. You plan, then you have a magic knife, you take it there, you need to cut 20 mm and you will be there. So these are some things which we will see downstairs. Now, anything, I'll give you one basic example. Let us say you need to transmit something from Maurya. So you need a satellite. So in here we say arrays, pelvic arrays, or in case of knee we have arrays that has got discs. So VISA disc basically they transmit signal from the body to the system. So you have the pelvic arrays. Checkpoints, there are 2 systems known as checkpoints. So these checkpoints are very important for the computer because the robot identified their checkpoint. If your patient droops anteriorly, the robotic arm droops anteriorly in hips and knees as well, which we will show you very well when we are doing stuff. Importantly, when we are doing a total hip replacement, especially, we are not sure about the position of the patient. Why? Because frankly speaking, we don't have the adequate lateral bolsters, because according to papers JBJS 2016, appropriate placement of the position needs 2 bolster, one at the ASIs on the same side and one at the pubic symphysis. Everybody, even best instruments, they have, you need to tell them, the table persons, the OT table persons which supply, that you need a bolster which is pelvic support and one going up. So when we talk about the OR layout, it's very simple. You'll see the gadgets not very big, but precision is 100%. So we place a pelvic array on the iliac crest, and then these are the satellites. What I'll say in layman terms, satellites. And then we routinely go what we want to do. These are the checkpoints which we have to put it in the acetabulum 1 and 1 in the femoral bone. These are for the computer locates that checkpoints, and it is beyond the scope why, how does it do, but it reads checkpoints. Now we take the leg length. So these checkpoints are landmarks which we take it, and then at the end of the day you can calculate the leg length, 1 mm long. Okay, we can increase the head size by, so it adjusts. We have so much options. And this is how we put the checkpoint on the acetabulum side. Neck cut, as I told you about the magic knife, we measure on the CT scan, the pre-op planning, and it is very well known that if you fail to plan, you are planning to fail. So we cut exactly as we want, and the magic knife takes us there. I will show you something more when we are doing the live surgery. But the most important thing when you are doing a hip replacement is to have a good acetabulum exposure, 360 degrees. And for that, you need to have good retractors, proper instruments, and we'll take it from there. So once we expose the acetabulum, we have to register. As I told you, like in Tinkle comic time days, we used to put 1, 2, 3, 4. We have to landmark, identify landmark, and the landmarks are taken, accepted by the computer, and then it has to be turned to blue. That is a verification. That is you're in the range of 0.5 mm of accuracy. And then, as I told you about the femoral intraoperative planning, we also enhanced version. We also have control of the broaching angles, antiversion 5 degrees, 10 degrees, 15 degrees. So we calculate both cup antiversion, stem antiversion, and combined antiversion, leg length, all is on the screen. You can mix and match, increase size, you know exact size of the stem. So this is how we do the registration. We take it from there, and then in the Mako system, that is the enforced control robot, we just do single rimming. That is, if the cup is 54, we'll directly go to 54, and one rimming, you are done. You'll stop where you have planned. If you have planned for 18 degrees of antiversion and 42 degrees of inclination, that's the final point, and we can verify it. But the point is, as Joseph Perry has told, and I elaborated in my slide, keep the old friends also. So we also have free rimming technique. Like we know how one rimming it goes, but it takes time to adjust. So we can do rimming in guidance of the computer. You can start from 42, 44, 46, and then gradually reach up to 54. Now, impaction. Impaction is also done by the computer, and it will tell you that it is 1 mm proud, 0.5 mm proud, and then 0 to 1 mm is acceptable as per the literature. Proudness of the cup, that is 1 mm I'm talking about. Now, we are on a big platform. The robot gives us visual feedback if you are going wrong. It gives us tactile feedback if you are going wrong. It gives us audible feedback we are going wrong. And last but not the least, yes, we kept inclination as 35 degrees, and the verification it was 36. Version we planned 20, so we got 20. And I'm preparing a paper which shows how much it is variating from the CT scans post-op. So we cannot plan 36 degrees of inclination by normal eyes, that's clear. So this is how we take the check results, and combined antiversion assessment. All these things compiled at one go. Stem preparation. When we talk of the stem preparation, we can pelvic arrays and know where the stem antiversion, how much you want, what is the range, and take it from there. All these needs initial femoral landmarks. I told you about the magic knife. We know the green, and we have to take it there, and it will show that yes, it is 0, 0, and then you mark it with a cautery and cut it there. So we don't need to say to our future generation that our thumb is as good as the size of the cut from the lesser trochanter. And then obviously you have the appropriate exact plan of the stem. So roughly, if the stem is 5, it can go to 6 or 4, but it will not be 2 or 3. So you will be knowing that yes, according to every calculation you are there. And we know about the broach stacking. These all must be looking complicated. But in couple of hours, I'll show you a live surgery, and we'll just go down and see how much we can understand all these things. Apart from that, in the software, we have the enhanced workflow and the version 4, where we can flex, extend, see abduction, adduction, inclination, and impingement. That is, you see the virtual range of motion before you start. And the best thing is that you can see the post-op X-ray before you even start the surgery. So roughly you know that your post-op X-ray would be like this. So this video is not working, but spinopelvic dysfunction. Before I end this talk, one thing I would like all of you to learn from my side, to get X-ray spine before you embark on a total hip replacement. There is a difference between all these things. Also, you need to know that what is the difference between navigation and robotics. Navigation will guide you, you will cut and then verify. Here, till navigation it is the same, but the robot will cut with your guidance. You cannot go wrong. So navigation was one generation earlier. But in my talk tomorrow, I'll show that in specific cases, you have specific things which is useful. Sometimes navigation is useful, sometimes this is useful. So coming to some results, as I told you, you are on target most of the times. So this target is within the target zone. Now, there are some studies about the anti-version. Yes, it is accuracy. Yes, accurate. It allows accurate reduction of the femoral native anatomy. And we are just resurfacing the acetabulum. We are not taking out more bones. It is just 0.5 mm. We are so particular in things. So things are getting better. We can plan so much on the robot. We'll all shift down and work on the robot so that we all should know, understand. Bone preservation. Bone cuts are so less in the robot that we are always there. The functional outcomes are definitely good. One of our papers is getting published, but believe me, patients are doing active SLR within 2 hours of the surgery, mobilizing within 4 hours, and as per our physiotherapist team, the pain scores are less and our definitely patients' outcomes are better. And these are some references what I talked about. So conclusion, I would say, why then we are still using traditional conventional techniques despite all the evidence? If you are a patient, what would you choose your surgeon to do? A 60 to 70% accuracy or a 100% accuracy? And that's what we should think for the patient. Technology adaptation takes time. It took time for us all to adapt from manual transmission to automatic transmission. But I believe everybody now has got manual transmission cars and everybody is on touch screen telephones. So if you adopt, you'll adopt and take it from there. So another big question which comes, registration time. How much time extra you are doing on the registration time? So this is the average minutes of registration time. So actually, I'm sorry, but we complete our hips in about 35 minutes. So our registration time is not more than 5 to 6 minutes. But we plan more and take it from there. So change is the law of nature. It is already coming, already happening in some surgical procedures, tele-surgery, and progress is inevitable. Technology is here to stay. Those who will perish, those who will stay, will perish, and those who will not take it, they will retire actually. In cases of fused hip, the paper has been published, but in fused hip, it is of superb importance. I mean, the robot will just take you there where you want to be. So, patient mobilized 8 hours. This is the post-op X-ray, the post-op bony ankylosed fused hip X-ray. And I'm very proud to say that this is the first paper on the Mako 9 ankylosed fused hip, bony fused hip, published in SICOT journal, which just published last month. So only the forms will change of the technology. The robot might become smaller over the day, it might become a chip, but we'll all be there. So without wasting much time, we'll shift down to the Sorbonne session or the Mako robot actual demonstration. I would like all of you to see, understand, and take it from there. I gave you a brief talk just to highlight what we'll talk down. But now I am not going to plan. It is you who will plan, and with the robot and the surgeon will execute. So learning points from my talk is that there are many forms of robot. The system which you are seeing is an enforced controlled robot. But tomorrow, one live surgery which is being relayed from Calcutta, it is a fully automated robot. So you'll see the difference. Now, navigation and this you have to understand. And third, that most important thing, definitely the world is shifting towards the robot. And then you'll have the masters, that is Frederick Picard, who is coming today evening and tomorrow. He's going to speak having a few lectures, who is the first person in the world in 1997 to do a computer-assisted orthopedic live surgery on a patient in France. So he is there with us over the 2 days. Probably he might have joined us as well. And we'll try to make this event very good. And with these few words, I'll end my talk. And I would like you to proceed to the Lumini Hall, because the robot could not have been shifted. It is roughly 700 kilos. And so I have tried to set up things in the Lumini Hall to feel the robot and take it from there. Thank you. Any questions? So we'll shift down, sir.
And I'm going to use total knee replacement and CAS.
यहाँ पे chairperson कौन है? Welcome back. We'll be starting in a few minutes. A very good morning again. So now we are starting a new session. Can we avoid a joint replacement? May I request our chairpersons? First of all, I see Dr. Ramit Gunjan sir here. May I have you on the dais, please? I think Dr. Vijay Shankar sir, I saw, he's not here. Dr. Ranjit Kumar Singh sir. So may I request Dr. Prakash Dhillon sir, he may chair the session, please. And may I also request Dr. Vinod Thakur sir, if he's here, if he can chair the session, sir. So, first on the list to speak about knee salvage is Dr. R.N. Singh. Dr. R.N. Singh is the chairman of ANUP Institute of Orthopedics and recipient of Padma Shri Award. And he'll be speaking on altogether a new stuff, stem cells in current trends and the newest current trends. I would like to hand over the further scenario to Dr. Ramit Gunjan and our chairperson, sir. Thank you, sir. Dr. R.N. Singh, sir, please kindly.
Thank you so much, Dr. Ashish. And I welcome all the delegates for this prestigious ANUP Memorial Course. And our speaker for this session is the Most Honorable Dr. Padma Shri R.N. Singh sir, and he will be speaking on stem cells in arthritis, current newest trends.
Thank you, chairpersons. I am heading towards 75th year of my life, and I have been asked to speak something which is very new, and it's the most recent thinking in the medical world. That a stem cell in arthritis and the current newest trends. You see, when I was a medical student, way back in 65, 70, we read stem cells in embryology, but we never thought the stem cell will be used for the treatment also. And then in the last 50 years, everything has changed. Now we can have whole Encyclopedia Britannica in one chip. We can have everything flashed all over the world in a moment, because everything has changed, and so is the medical management of many diseases have also changed. I'm going to talk to you something which is new but old also, because a lot of people have been working on this subject for years together to reach to this point whom I'm going to talk today. First of all, I must say, what is stem cell? Stem cells are underdeveloped biological cells capable of proliferation, self-renewal, conversion to differentiated and regenerated tissues. It can grow into muscle, bone, fat, cartilage, and it can also work for the reduction of inflammation, and also it can self-replicate. The need, what is the need of talking about this particular subject? Stem cell research arose from the need to explore new therapeutic possibilities of intractable and lethal diseases, like sickle cell anemia, the aplastic anemia and others. But although the musculoskeletal disorders are basically non-lethal, their high prevalence and relative ease of performing clinical trials have facilitated the clinical application of the stem cells in this field. Therefore, focal osteochondral defects, osteoarthritis are current targets of cartilage regeneration. To date, the literature supporting stem cell therapies comprises mostly case reports and case series. It is imperative that clinicians who adopt stem cell treatment into their practice possess a good understanding of a natural course of the disease. So, what is a stem cell and how many types of they are? There is one totipotent cells. This can develop into all types of human body, cells of the human body, also form an extra embryonic and placental cells found in early stages of embryo, but not in clinical use due to some ethical concerns. Then pluripotent cells develop into cells of all three germs, that is endo, ecto and mesoderm, represent cells of stages of embryo after the blastocyte stage. The multipotent cells develop into more than one, but not all germ layers. Adult blood cells and cord blood cell are multipotent. Now, there are two major groups of these types of stem cells. One is prenatal, that is embryonic, and postnatal, that is adult. The pluripotent blastocyte stage of embryo can form any tissue in the body, multiply in unlimited manner. Therefore, the risk of asymmetric division, tumorigenesis, and safety and ethical dilemma. Therefore, the use of prenatal embryonic stem cells guarded because of the different regions. But the postnatal multipotent, after the embryonic stage, its primary function is maintenance and repair. Mesenchymal stem cells originate from the mesoderm, good potential to develop into adipocytes, chondrocytes, myoblasts and osteoblasts. Therefore, this type of postnatal adult stem cells can be used. But how can we get it? As well as bone marrow, the skeletal muscle adipose tissue, the placenta, umbilical cord, blood, human amniotic fluid, dental pulp, synovial tissue, the skin and periosteum. All these sources we can have stem cells. Now, stem cells form bone marrow from adipose tissue, and it can go to any. This particular chart shows that stem cell therapy for osteoarthritis in India, we are trying to develop this everywhere. It can be used. And if we go, how do we use it is the isolation. How do we isolate the stem cells? This is unselected cells obtained from autologous bone marrow after centrifugation. Selected cells, the above step with enhanced in culture, utilizing their affinity to tissue plastics. Now, you can centrifuge it and get it, or you can culture it and later get it. That is, we will be talking about PRP method of treatment later on. You will look into that matter again. Now, route of administration. It may be directly applied into the lesion, either surgically or local injection with a suitable scaffold or carrier. Intravenously, it can be used. Their ability to migrate systematically and colonize the bone marrow after a peripheral injection has been utilized for treatment of osteogenesis imperfecta. The mechanism of action again, the differentiation into bone, muscle, cartilage, ligament or tendon cells, the paracrine effect whereby they secrete growth factors and cytokines such as bone morphogenic proteins, transforming growth factor, that is beta, and vascular endothelial growth factor, that VEGF. Now the key advantage of this is that the first, due to an autologous nature of these cells, autoimmune rejection risk is eliminated. Second, MSC can be isolated in relatively high quantities and with excellent purity, thus optimizing the potential or differential into target tissues in the damaged joint space. Third, like other products of regenerative medicine, MSC possesses robust anti-inflammatory properties in that they express 1L1RA and can directly antagonize resident macrophages of the joint spaces for secreting peri-inflammatory cytokines. Fourth, human MSC can be cultured and expanded via vivo using good manufacturing practices, offering an opportunity for additional pharmaceutical treatment to enhance cell proliferation, maturation, as well as their repair potential. And lastly, MSC can be utilized in human clinical trials for the past 10 years for widespread application, which demonstrates that they are safe, effective method of translational therapies. Clinical use. Now, stem cells for treating long bone defects. To facilitate regeneration of currently intractable large bone defects, stem cell therapy has emerged as a possible solution. Application of stem cells in osteonecrosis. Osteonecrosis of the death of osteocytes and subsequent structural change leading to collapse of femoral head, that is AVN we call, a secondary osteoarthritis of the hip joint. And this occurs in young, this necessitates the premature total hip replacement. We can prevent it or longer, we can go for some time before doing the total hip replacement, a method that reduces bone regeneration with minimal surgical intervention is needed for those young patients. Now, Angravu et al. First hit on the idea of a stem cell therapy in osteonecrosis of femoral head, that is ONGAF. They added that the BMAC to cord decompression, a series of publications reported by positive results of BMAC implantation in treatment of osteonecrosis of femoral head. Several controlled studies have been published recently on the application of BMACs in treatment of osteonecrosis of femoral head, most of which reported a beneficial effect in the implantation of BMACs for culture and expanded MSCs. Stem cell for fracture healing. Now, these people have reported combined use of Elizarov external fixator with BMAC and PRP to expedite healing of bimalleolar fractures. A stem cell application for regeneration of articular cartilage and treatment of osteoarthritis. Unlike bone, which is self-regenerating tissue, the case of articular cartilage represents a dilemma in regeneration of damaged tissue. Articular cartilage has limited potential for self-regeneration, and damage to it eventually leads to development and progression of osteoarthritis. So a stem cell for osteochondral defects, while cytology for cartilage regeneration began with autologous chondrocyte implantation, ACI, the advantage of MSC are increasingly recognized. OA presents a greater pool of affected patients than osteochondral defects. Following the promising results of vivo implantation of stem cells in large animals, model of OA, a sporadic series began to be reported. Now, once we found that we're getting better results in animal models, we started using it in human beings. However, as is the case with osteochondral defect, few studies have evaluated the clinical use of a stem cell to treat osteoarthritis. Do a stem cell for knees work? This is a big question, and we are here to talk about that. A role in inhibiting catabolic activities of matrix metalloproteinase, MSC have been shown to have a beneficial effect in OA. According to studies conducted in the Czech Republic, Korea, and United States and other centers, approximately 2,000 patients between the ages of 18 to 94 participated in this study, and this study, higher concentration of stem cell had a better effect. Young people in patients with stage 2 arthritis gave the best response to the treatment. After cell therapy, 67 patients showed complete healing of cartilage defect of the joint. Within 3 months, 81 to 53% patients showed 50 to 75% improvement in degenerative joint disease. After 6 months, these indicators have increased to 10 to 13%. It was confirmed by MRI, arthroscopy, and histology results. Culturing BM-MSC medium rich in factors has been proven to generate the natural joint environmental components, type 2 collagen, D-chroin, chondroitin, adenine, cartilage, oligometric matrix protein, fibromodulation, and aggregation link protein, and other proteoglycans. In addition, the compound chitogenin has been studied in mouse model which facilitate BM-MSC differentiation into type 2 chondrocyte and secretion of accompanying extracellular matrix. Stem cells reduce inflammatory process and providing lasting effect in therapy. They help truly heal the damaged areas and prevent complications, inhibit catabolic activities of matrix metalloproteinase, and MSC have been shown to have a beneficial effect over. Thank you very much.
Thank you so much, sir, for providing such a detailed insight into a topic which seems so promising and promises to be the next big thing in the future of orthopedic practice. Thanks a lot, sir. And now I would like to request our President, BOA, Dr. Bharat Singh, sir, to please felicitate Dr. R.N. Singh, sir, with a memento. Dr. Bharat Singh, please.
One thing I must add after giving this lecture, that if this kind of treatment goes up, the chances of knee replacement goes down. So that's a good way of saying things. Come along, sir.
Thank you, R.N. Singh, sir. Thank you, Bharat Singh, sir. And moving on to our next topic, we have yet another very articulate speaker, and we are all very fond of listening to him. But unfortunately, due to his prior commitments, he is not available with us in person, but he'll be presenting his paper on the virtual mode. Dr. Professor S.S. Jha, sir, and he will be talking on controversies in primary TKA and THA, role of nutraceuticals, and non-operative treatment of osteoarthritis, knee biologics, and other things you can inject into a joint, what really works and what has no proof. Please unmute Dr. S.S. Jha, sir. Please unmute yourself.
Able to do that. Can you hear me now?
Yes, sir. You are audible. Please go ahead.
Right. And my screen is visible?
Yes, sir. Yes, sir.
Okay. So, friends, I am going to talk about various modalities of especially intra-articular injections that are available. Before that, I would like to say whatever treatment modalities are available are not effective. And I would like you to take back to 1990s, where discovery of inflammatory theory in osteoarthritis was propounded. It was due to progress in molecular biology, and it profoundly modified understanding of OA pathogenesis. This discovery of inflammatory theory emphasized that there are many soluble mediators such as cytokines or prostaglandins which can increase the production of matrix metalloproteases by chondrocytes. And you must remember Dr. R.N. Singh has very recently just now told you that these MMPs have very greater role. These theory of inflammation was not accepted till 2000, but now it has been accepted, and now synovitis is a part of osteoarthritis. It is a critical feature and driver of arthritis process. My slide is not moving, some technical problem. Yes. So let me talk about recent advances in management. And we go straight away to one particular drug which goes by the name of sprifermin. Now there was a forward trial and it said that it increases the cartilage thickness. Let us try to understand. A drug which can increase cartilage thickness will be of real help. It substantially reduces cartilage loss, and the structural benefits which are seen at second year are sustained even at 5 years. It can be given in a dose of 100 mg every 6 months or 12 months. This still unfortunately has not been approved by FDA. This is a biological intra-articular drug. The other one is loresivivint, which also can be given intra-articular. This is evolution of a small molecule inhibitor of WNT signaling pathway, and it has disease modifying possibilities. There are claims of significant difference in joint space width. Here also the joint space width is increased and might cause cartilage regeneration and protection from cartilage catabolism. Friends, WNT signaling pathway stimulates production of catabolic proteases implicated in matrix degradation. So naturally its inhibition will have regenerative effect. This drug which has been approved by FDA, this is nothing but repurposing of existing triamcinolone. There has been technological advance in targeted delivery approach, and FDA approved, as I have told you. It is an extended release formulation of synthetic, not biologic, synthetic triamcinolone acetonide in PLGA microspheres, and it maintains concentration in the joint for several months after a single intra-articular dose, and greater pain relief exists for 5 to 10 weeks and still more. Another one, as Dr. R.N. Singh has told you now, stem cell will be available from 22nd September in Bihar in India. They are in the name of STEM 1. This comes in a frozen cryo bag. Cryoprotective gloves will have to be used for handling them. They are stored at -185 degree to -196 degree in vapor phase of liquid. They are adult human bone marrow derived, cultured, pooled allogenic mesenchymal stromal cells. They are effective in osteoarthritis of the knee. Cost is 1,20,000 rupees. Friends, this will be of utility in stage 2 and early stage 3 osteoarthritis. A similar product is available by the name of Regena SIP, and it has been reserved for use in critical limb ischemia. Let's, friend, also talk about something which already has arrived, and this is intra-articular gene therapy. South Korean Ministry of Food and Drug Safety have approved this first arthritic gene therapy goes by the name INVOSA. There is direct intra-articular injection, and the gene delivery is by adeno-associated virus, very safe virus which works as a vehicle. It transduces the synovial lining cells as well as chondrocytes throughout thickness of the articular cartilage, and chondrocyte dysfunction, so there is considerable disadvantage. Now coming to the first part of the topic, you wanted to speak me on nutraceuticals as well. There are several, but before I start talking about any one of them, I would like to overemphasize that there is a nutraceutical known by the name of Silmarine, and this Silmarine usually is prescribed for liver products, is also a very good potentiation of regeneration in osteoarthritis. Well, the other ones all of us know, turmeric, the curcumin, is an anti-inflammatory, antioxidative, anti-carcinogenic. Glucosamine and chondroitin sulfate, used since long, also have anti-inflammatory activities because they regulate gene expression and synthesis of NO and PGE2. But personally speaking, I always favor use of aflapine, which is the most efficacious anti-inflammatory agent, better bioavailability, and it has 5-lipoxygenase inhibition and MMP3 inhibition. It reduces inflammatory mediators, tumor necrosis factor alpha, interleukin-1 beta, and intracellular adhesion molecules, and improves glycan level, thereby reducing pain and inflammation, prevents cartilage damage, and controls disease progression. Well, collagen, rosehip, and soybean are other drugs which are used. I will once again overemphasize that aflapine is not being prescribed in proper dose. The proper dose is minimum 250 to 500 milligram daily. So it should be prescribed in that particular dose to be effective. Now coming back quickly to the biological DMARDs and synthetic DMARDs. The biologics, I must mention, are not effective in osteoarthritis knee, even administered intra-articularly, and they are adalimumab, etanercept, infliximab, not effective. But if there is a reactive arthritis, they can become transiently effective. The conventional synthetic DMARD, hydroxychloroquine, and even methotrexate, they are not effective in knee osteoarthritis. So I would like to conclude that Loresci, Vivint, Gilreta, STEM1, and the future lies in intra-articular gene therapy in VOSA, and small molecules targeting bone remodeling also raises hope in treatment of osteoporosis and osteoarthritis by regenerating both bone and articular cartilage. Thank you very much.
Thank you so much, Dr. S.S. Jha sir. It's always a pleasure to learn from you, and yet again, this paper was so informative from your side. We miss your physical presence today, but looking forward to listening and learning from you in future yet again.
Let me greet all of you from Goa. Thank you.
Thank you. So we move on to our next speaker, and Dr. Ashish spoke very high of him, Dr. CHIRAG THONSE. As we know from Dr. Ashish, he is a very prolific arthroscopic surgeon as well as a plastic surgeon. He'll be speaking on management of young arthritis knee, what's latest and what should be done. Dr. CHIRAG, over to you.
Good afternoon, one and all. On the outset, I would like to thank Dr. Arun Singh and Dr. Ashish Singh, a very good friend of mine, for this invite. It's my first time to Patna. And my topic for the day would be management of young arthritic knee. With fitness being in vogue, we all say 50 is the new 30 or 60 is the new 40. There's an increased zeal towards fitness, and this has caused a lot of brunt on the knee. And there are a lot of issues in the knee which the youngsters in today's date are facing, and one of them is arthritis. There have been lots spoken about orthobiologics. The conventional treatments of knee osteoarthritis could be extended, and now there are a lot of orthobiological treatments which have been well explained in the past by my previous two speakers, and that it's got its own definitive role in the treatment of young arthritic knee. So let me stick on to the surgical management. What options do we have in patients presenting to us with arthritis when they are young? Arthroscopy, high tibial osteotomy, partial knee replacements, and total knee replacement. Of this, arthroscopy is obsolete in today's date. Plain arthroscopy or arthroscopic lavage is no more done to treat osteoarthritis. So let's stick on to the treatments which are available in current date. Either arthroscopy added on with a high tibial osteotomy alone, a partial knee replacement, or a total knee replacement. Now, why does one sustain, or why does one encounter arthritis at an earlier age group? It could be either idiopathic, inflammatory, traumatic, or post-ligamentous injuries. Among this inflammatory arthritis, not much of an options. One wouldn't suggest a high tibial osteotomy or a partial knee replacement. The only option here is to go ahead and do a total knee replacement. Let's quickly look into a day-to-day case scenario. 42-year-old active tennis player comes to you with a low velocity injury, no significant past history, complaints of pain and deflection, and since a few months he's got difficulty in walking. Varus deformity of the knee, medial joint line tenderness, very minimal patellofemoral joint tenderness, and the patient has got no ligament laxity. Extrusion test is positive. All the conservative treatment modalities failed. The patient then does come to you and you get an X-ray, and this is a typical picture what you see. Medial joint line reduced, patellofemoral joint pristine, and the lateral joint line well preserved. It's very important in such situations that you get a good Rosenberg view to get a good visualization of the joint line and to plan up your surgical interventions. We always do get an MRI scan. Any patient who is presenting with you with the medial joint line tenderness, minimal arthritis, or an early onset of arthritis, go ahead and definitely get an MRI scan, because that will give you a well-detailed study of your cartilage and your meniscal status. Now, as you see here, there's a ghost sign which is positive, which says that the patient has a root tear of your medial meniscus. There's a high intensity signal on the axial films that does say that there's something going wrong in the posterior compartment of the knee joint. Whenever you see a condylar contusion or whenever you see osteonecrosis of a tibial condyle or a medial femoral condyle, always suspect a meniscal root tear, and you would see here that that one would have a meniscus which is extruded, saying that the medial meniscus is non-functional. Get a long leg standing view. A good long leg standing view would give you a good alignment idea. It would draw in a maculic line, which is the mechanical axis, and then do calculate your distal femoral angle, your MPTA, and of course the joint line congruence angle. And based on that, whatever you would find deformity needs to be corrected. If it's only a MPTA which is out of parameters, go ahead and do a arthroscopic meniscus root repair added on to a high tibial osteotomy, or if you see that your LDFA and your MPTA both are out of parameters, one would definitely go ahead and do osteotomy at two planes, at both ends, distal femur and the proximal tibia. Another case scenario, 50-year-old housewife, moderately built with a little bit on a higher BMI, low activity demand, stress X-ray, the medial joint line is correctable. On scoping, you have a bone-on-bone deformity. These are patients with a high joint line congruence angle. These are more of a bald cartilage or a bone-on-bone deformity where there is attenuation of both your tibial and your femoral articular cartilage, and you have a high grade of osteoarthritis. Managing these patients, of course, high tibial osteotomy on a bone-on-bone deformity is out of question. A partial knee replacement would be an ideal option. Why I say so? Because of the high, it's an intra-articular deformity rather than extra-articular deformity. The patient is correctable. That means the MCL is quite stretchable, and low activity demanding patient with a little bit on a higher BMI. It's very important to note here that unicompartment knee arthroplasties implanted for osteoarthritis with partial cartilage loss, joint space or a partial joint space narrowing have got high reoperation rates. Said that, the crux of the story is that partial knee replacement works well when there is a bone-on-bone deformity and a high grade of osteoarthritis in the medial compartment. Stress X-rays, if it's a non-correctable deformity, if you are not able to correct the medial joint space with the stress X-ray, that says that the MCL is contracted, and these patients are not an ideal indication for a partial knee replacement. One might as well go ahead and do a high tibial osteotomy. Obesity, this is a common problem we all face, especially in urban population, where obesity has become a trend, what I would say. It is difficult to manage these patients with the high tibial osteotomy, and definitively a partial knee replacement would be a better option in such patients. A body mass index of 40 or 45 is also acceptable, and one could go ahead and do a partial knee replacement. Ligament laxities, anybody walking with a valgus thrust gait or else mediolateral instability, a high tibial osteotomy or a partially constrained total knee replacement would be the procedure of choice rather than go ahead and do a high tibial osteotomy. Chronic neglected ACL tears, a young individual coming to you with about 10 or 12 years of neglected ACL tear, medial compartment osteoarthrosis, and a grade 3 laxity. What are the options you have? When you scope the knee, you would find that there's a high grade of posteromedial wear, which happens because of repeated twisting injuries, and there's a degenerated meniscus. An ideal option would be to do an ACL reconstruction with the high tibial osteotomy. If not, just go ahead and change the slope. That's a slope correction high tibial osteotomy would also suffice. A combined unicompartment knee arthroplasty with the anterior cruciate ligament reconstruction. There have been a few literatures which talk about this procedure, but the long-term results are yet to be expected. Last but not the least, this is the most common problem what we encounter. Patient coming to us with the anterior knee pain syndrome. The grade of patellofemoral arthritis when patient presents to you may be a milder grade, or they may come up with severe problems. In a grade 1 or a grade 2 patellofemoral arthritis, what one could do is do an arthroscopy, do a radiofrequency ablation, and do a lateral release, which would give a longevity to the patellofemoral compartment. If a patient presents to you with something like this, a bone-on-bone patellofemoral deformity with osteophyte, typically called as a penguin patella, a patellofemoral replacement would be the procedure of choice. To sum up, the measure of, as Einstein said, the measure of intelligence is the ability to change. So rather than being just an arthroscopy surgeon or an arthroplasty surgeon, it's better that we all call ourselves as a knee surgeon and provide the best possible treatment to the patient as per as the patient's demand and the pathology. Once again, I would like to thank my dear friend Dr. Ashish and the entire organizing team of ANUP Orthopedic Course for inviting me to this wonderful program, and welcome you all to Bangalore for the upcoming Bangalore Arthroscopy Operative Course, which will be held on November 26th. Thank you.
Thanks, Dr. Chirag, for your nice presentation. Now, Dr. Ashish will give you memento. Now I call Dr. Pankaj Kumar Singh to present his paper. Dr. Pankaj, please. Use of platelet-rich plasma and bone marrow aspiration, concentrate injection to treat knee osteoarthritis. Pankaj.
I am here to talk about use of platelet-rich plasma in osteoarthritis. Now, in early osteoarthritis, can we do anything promising from the traditional treatment options to help the patients? Now, the various traditional treatment options are rest and braces, physical therapies, medications, intra-articular steroids, and of course, surgery. Is there something wrong about these traditional treatment options? For the rest and braces, physical therapies, no. But the medications, yes, they do cause ulcers, gastritis, systemic disorders. Intra-articular steroids, yes, they temporarily reduce the inflammation, but they inhibit the healing process and cause cartilage and soft tissue damage. Surgery, they of course has intra and post-operative risks. Any other options? What about platelet-rich plasma? It is a natural way to stimulate the body to heal the damaged tissues. Now it is defined as a volume of plasma that has the platelet count above the baseline of the whole blood. That is 10 lakhs per ml or 3 to 5 times that of the peripheral blood. It was first developed in 1970 and used in 1987 in open heart surgeries. It gained popularity in mid-1990s for the treatment of arthritis, ligaments and tendon injuries. Now the types are pure PRP, leukocyte-rich PRP, pure platelet-rich fibrin, and leukocyte and platelet-rich fibrin. Some of the new techniques are titanium plates having enmeshed PRP. Now the preparation of PRP, standard PRP preparation method and Buffy coat method, where we collect around 27 ml of whole blood and we centrifuge it with an anticoagulant, ACDA. Then we centrifuge it with 1900 grams of 1900 gram centrifugal force for around 5 minutes, and then we get 3 layers. First is the platelet poor plasma layer, then is the Buffy coat, and last is the RBC concentrate. So we separate the upper and the Buffy coat to another tube, and then we give another 1900 gram centrifugal force for around 10 minutes. That is called hard spin because the rotations are higher. So this is the method. So the process of injecting is like any other intra-articular injections. We can use any of the methods you like. Now arthritis, the problems are cartilage wears out, poor lubrications, and the resultant inflammation causes pain. So the bad molecules which causes the inflammation are matrix metalloproteinases, collagenases, interleukins 1, tumor necrosis factor, and disintegrins. They mainly cause catabolic breakdown. And the good molecules are tissue growth factors, tissue inhibitor of metalloproteinases, interleukin receptor antagonist proteins, and alpha-2 macroglobulins. They block the bad molecules. So what the platelet-rich plasma does is reduce the bad molecules and increases the good molecules. It augments the tissue healing through the natural healing cascade. This cascade consists of 4 steps, that is chemotaxis, cell differentiation, cell proliferation, and angiogenesis. Like during PRP therapy, it conveys the fibrins and the growth factors as effectors. So these growth factors affect on the entire joint and promote the restoration of joint homeostasis, inductive and protective effects on the chondrocytes. It stimulates the hyaluronic acid production by the synoviocytes. And all these properties help to promote a generative biological environment and to slow down the joint and cartilage degeneration, thereby relieving symptoms. Like some of the uses in orthopedics are knee osteoarthritis, lateral epicondylitis, rotator cuff injuries, non-union like titanium enmeshed plates, Achilles tendinopathy, patellar tendinopathy, plantar fasciitis, wrist arthritis, ankle sprains, and shoulder osteoarthritis. Like outcomes, Kohn et al. In a study of 150 patients who received PRP, they gave better clinical score at 12 months. Spakova et al. In study of 120 patients found significantly better results in the WOMAC scoring. Like numerous studies have been done previously in the past and still going on. Smith et al. In 2016 did a comparative study between PRP and placebo group, where he injected a normal saline in one set of patients and in one set of patients PRP. He found that from 2 weeks onwards, PRP was significantly superior to the saline placebo up till 12 months, and it improved the WOMAC scoring. Sarza et al. In 2012 compared the results of PRP versus hyaluronic acid, and the results were PRP showed significantly better clinical outcome than treatment with hyaluronic acid, but the effects were limited only up to 6 months. So treatment with hyaluronic acid does not seem to be effective in the patient with grade 3 osteoarthritis. Kanchat 1 in 2015 suggested that PRP injection is more efficacious than the hyaluronic acid and placebo in reducing symptoms, improving function, and improving quality of life in patients with mild to moderate osteoarthritis of the knee who have not responded to the conventional treatment and therefore can be considered as a treatment of choice. Now, R.N. Singh sir has already talked about bone marrow aspirate, but it has been taken from the posterior iliac crest, and usually 2 ml of this bone marrow aspirate has been taken, we took and been given into the joints. These mesenchymal stem cells are the multipotent progenitor cells that can be obtained from the bone marrow, adipose tissue, synovium, articular cartilage and skeletal muscles, and they present self-renewal and differentiation potential. So the advantage of mesenchymal stem cells are they are autologous, there are no major ethical constraints, they can be expanded in vitro, they can be cultured, and they do not express HLA2 antigens. But their mechanism has not been fully understood, and the hypothesis is these mesenchymal stem cells potentially provide a direct cell source for the tissue repair. And these nucleated cells have a paracrine effect by delivering the various growth factors and cytokines into the lesion site to promote the tissue healing and immunomodulation. These mesenchymal stem cells also have immunosuppressive effects by adjusting the activation of natural killer cells, dendritic cells, macrophages, and TNB lymphocytes. Thus, the mesenchymal stem cells have advantageous anti-inflammatory and anti-fibrotic actions to maximize their therapeutic effects. In conclusion, the platelet-rich plasma and the bone marrow aspirate are successful modalities for the conservative management of osteoarthritis, as it not halt the progression of disease but also the bone healing. Thank you.
Thank you, Dr. Pankaj. Please stay back and receive a memento from Secretary BOA, Dr. Mahesh Prasad, sir. It was a wonderful talk, Dr. Pankaj. Dr. Ashish, do we have ample time? Can we invite a few questions?
Yes, sir.
Okay. So, the House, we invite questions from the delegates. Questions from delegates to all the speakers for this session. So, Dr. Pankaj, as we don't see any questions from the House, in the meantime, could I ask you a couple of questions?
Sure, sir.
So, I have question related to your topic, which is in 2 parts. Firstly, your personal experience regarding PRP use in clinical practice, number 1. And number 2, there might be many of us who do not have a regular access to a centrifuge at our clinical setups.
Yes, sir.
How can they bring about doing this procedure?
Sir, I have seen that these corticosteroids and this hyaluronic acid they are usually effective in the first 6 months. That is, their time of action is fast. The patient gets immediate relief. But the platelet-rich plasma, they actually cause inflammation and reduce the inflammation and immunomodulation. So the actual improvement occurs after 2 to 3 months. But we have to give the same protocol has to be given for this, like we give in corticosteroids, like 3 weekly intervals, like for PRPs also, for 3 doses. Then after 6 months, some patients have reported good improvement. And so it has been given in only in stage 1 or stage 2 osteoarthritis only, because grade 3 and grade 4, they are not, they do not have reported any significant improvement.
So would you advocate, I'm interfering you, the second part you can answer. Would you advocate the use of some other NSAIDs or steroids initially so as to give the patient some immediate relief so that he could
Yes, sir, we can do that.
feel more confident on you and you
Yes,
could
sir,
win
we can
his
do that.
confidence. Okay.
Like first time we can give corticosteroids, and after 3 weeks we can give platelet rich plasma for 3 doses.
Okay, that now the second part.
The second part is, sir, if we have a center who wants to give platelet rich plasma, so if they don't have any means for the centrifugation, what they can do is extract the blood and mix with anticoagulant like adenosine citrate dextrose acid, like ACDA, like 27 ml of blood and 3 ml of anticoagulants, and they can send it to a pathology lab where they will first centrifuge it and they will extract the platelet poor plasma and the buffy coat, and then they have to spin it again, centrifuge it again for around 15 minutes, and then that excuse me, and then they can send it back to you. So this process takes usually more than 1 hour. So that's why we have to use anticoagulants when we don't have a center for that PRP.
Thank you so much.
Sir, generally it is said that steroid should be avoided in weight-bearing joints. What do you say?
Sir?
Steroid should be avoided in weight-bearing joints like knee.
Yes, sir. But if the patient is having synovitis and some sort of, then it has been found useful, I think.
Thank you.
Thank you, sir.
Very thank you for this conducting this wonderful session. Now may I request Dr. Ashok sir if we can present a memento to our honored chairperson, sir. We are very delighted to have you here, sir. Firstly, Dr. Prakash Dhillon, he is all the way from Amritsar. Thank you, sir, for helping us. Our eminent orthopedic surgeon, Dr. Ramit Gunjan, sir. Dr. Vinod Thakur, sir. I am very thankful to you. With this, I would like to invite Dr. Anand Shankar, sir, to kindly take us from here.
So after the very informative and innovative session 2, so we are moving on to the session 3. So for chairing the session, I would like to call Padma Shri Dr. R.N. Singh sir, Professor Dr. V.K. Sinha sir, and Dr. Anup Kumar sir. Please kindly come and chair the session, sir. Please, sir. Then I would like to call our President BOA, Dr. Bharat Singh sir. Kindly chair the session, sir.
I would request Dr. Ashok Kumar Sinha sir to present his talk on THR in Indian scenario.
THR. Yeah. That. Yeah. Namaskar. Friends, today I am going to talk about THR in Indian patients. So, this is for real Bharat, not for India, I'm sorry. This is for real Bharat. After doing THR, can we allow our patients to go to Pandit ji to Mandir, Maulvi to Masjid, Sardar ji to Gurudwara, or Indian traditional Dina, Yoga, or Indian toilet? I think answer is no. So that's why every time we are counseling with our patient regarding THR, patient is to ask, sir, हम चुक्का मुक्के बैठ लेंगे ना, पालथी मार लेंगे ना, and we used to scratch our head. So we have to think out of box. We are not doing justice to our patients. So to do justice, we have to think. Allow our patients to sit cross-legged, squat, hyperextend, and hyperflex. Now the question is how to do it. Do anterolateral approach. 360-degree exposure of acetabulum is as usual. Acetabular cup placement in 15-degree anteversion or little bit more. Never neutral or retroversion. Cup inclination 45-degree or some more horizontal. Liner with posterior superior extra coverage is very advantageous. Femoral head and stem size should be according to optimum tensioning of the soft tissue. No loose soft tissue should be there around hip. Tight repair of capsule and abductor is must. Post-op protocol, partial weight bearing after 2 weeks, hip exercise after 3 weeks. Emphasis on hip abductor is very encouraging. After 6 weeks, aggressive hip range of movement and full movement by 3 months. Complications, dislocation, very rare. Since it is anterolateral approach, dislocation is so very rare. But in this case, we have faced dislocation because this was fourth surgery and soft tissue tension was very poor in this elderly lady. Periprosthetic fracture, it occurs in enthusiastic old age patients. Limb discrepancy again rare because the patient is in lateral position. Kinematics inside body, doubt we all have that by doing squatting and Buddha position, there will be early wear and tear of liner. No. Since thickness of head and liner is all around similar whole sphere, so there is no chance of early wear and tear. Maximum joint reaction force on hip is about at 90-degree, which we usually allow in any THR. At hip flexion more than 90-degree, the force is shared at knee. So there is no chances of early wear and tear. Kinematics inside C2. See single THR, see the movement. How the patient is squatting, sitting cross-legged, so smoothly, ball is moving inside acetabulum. No chance of dislocation is there, no chance of protuberance is there. Same thing in bilateral THR. How smoothly cup is playing inside acetabulum, while patient is sitting cross-legged, squatting. See how swiftly. Here I am going to share some of my cases, real Bharat patients. 35 years male, grade 4 OA, bilateral THR after 6-week interval. See, movement. Indian patient have to do it. My next case, bony ankylosis of left hip. There was marital issue here. She was not able to conceive after 3 years of marriage. After 8 months of post-op surgery, patient conceived. See the baby inside pelvis. Baby skeleton is there. And see the movement. Again, bilateral OA, female, 35 years, bilateral THR. See the movement. Three-month-old female femoral head fracture dislocation. Conservative treatment was given. Again, One female has to sit cross-leg. 7 centimeter shortening, a female. Their in-laws has rejected her to stay. She was at the verge of divorce because she was not able to do normal duty at their in-laws' house. Femoral head slipped at lesser trochanter with migration of proximal femur so high. Initially, tenotomy done and a skeletal traction applied for 3 days. Now, only 2 centimeter shortening is there, and see the lady. (16 years male, 2 years old non-union, arthritic hip. See the movement of boy. She is doing all activity as a normal boy. Protusia stimuli, 49 years. See the movement. This man, (16 years male, fractured neck femur, neglected. He was advocate. See, wrongly it has mentioned 9 months, it is 2 months post-op simply. And this Vakil Sahab, after 2 months of surgery. Again, arthritic knee. See the boy. (56 years, fracture dislocation of hip, complex primary THR, first posterior wall and THR at same sitting. See the lady. Lady from village side. She sits, she does everything. Dadima, very old lady, simple PH, partial. So we have to think. Tailor the coat as per body. Give what is asked for, not what you are having. To achieve this, keep the hip cup in anteversion, optimum soft tissue tension, post-op follow-up is must. Check during surgery by flexing the hip more than 130 degree and give thrust over knee. See the implant processes, whether it is dislocating, it will not dislocate. Have faith and allow the activities of daily living. This will give you and your patient both very satisfaction. Thank you. Jai Bharat. Question.
Thank you for this informative speech, sir. I would like Padma Shri Dr. R.N. Singh, sir, to facilitate Dr. Ashok, sir.
Yeah.
Yes, Mike, please.
Hello. This is the wonderful lecture by our past president, Dr. A.K. Sinha, sir. My question is, you just pressure on the dislocation of total hip replacement. And I think it's a wonderful surgery you have shown as a picture. But my question is, we are usually doing a THR and avoid squatting. So my reason is why. Why we are avoiding you don't allow to squat. So I think not only the thing or dislocation kind of thing, but also is the stress over the implant. So durability of or implant longevity to sustain inside the body is also a factor, or only a dislocation is a factor?
So far as wear and tear, the patient is standing, having full weight, full time on upper quadrant of the hip, upper superior. Patient is sitting for a while, the force is on posterior quadrant. Same thickness of material is in upper, posterior and inferior. So where is more chance of wear there? So I think this was myth, because European people are not required this squatting position and cross-leg position. They never propagated. My teacher, Professor R.C. Ram, used to say, in very medical college days, जब मरीज चुक्का मुक्का नहीं बैठेगा, पालथी मार के नहीं बैठेगा, तुमसे ऑपरेशन नहीं कराएगा. This was his word. Still I remember, and I followed those things, and I am doing the same practice.
Thank you, sir.
Any more questions? Yes. Please pass down the mic, please.
Hello, sir. Thank you very much. Which processes you are using? Which implant? Which implant you are using?
Implant?
And, yeah.
Should I disclose?
Sorry?
May I disclose? Yeah. Pardon? Company?
Yeah, company.
I think it should not be disclosed. But very common, whether it is Depot, Synthes, Merrill,
right.
Okay, it's like every.
And what about the long-term prognosis of your patient?
I am doing
follow-up. How much?
I am following this case since last 2005. It is, and the patients are bringing patients.
Okay.
They used to say, "वहाँ जाओ ना, चुक्का मुक्का बैठाएगा."
Thank you.
Thank you.
Thank you very much. Thank you very much, Dr. Ashok. Very nice lecture. I was really thrilled to see the people doing all sorts of activities. My observation is just one, that if you buy a good car, you must use it properly. If you buy a even best car of the world, and if you use it in a very bad road, the longevity of the car will become reduced. Therefore, you can do squatting, you can do all sorts of activities that you have shown. But the most important thing is that let the patient avoid this to have the longevity of your joints. That is what is my observation. And I think if the patient is satisfied, after all, we all do surgery for the satisfaction of the patient.
Yeah.
The painlessness and satisfaction of the patient. That's very nice. But for youngsters, I am asking, just saying that joint, जो hip joints and knee joints हम लोग सर्जरी करते हैं, उसका इज्जत उसकी रखो, उसको बदनाम मत करो. It's very important to keep the dignity of the joints. What happens that अगर एक पेशेंट खराब होता है तो 100 पेशेंट को ले जाता है. जब वाजपेयी जी का ऑपरेशन हुआ था तो उसके बाद एटलीस्ट 2 to 3 years we are facing single question कि जब वाजपेयी जी का नहीं हुआ तो हमारा क्या होगा. But the question was that Vajpayee ji was benefited by that operation. The pain that he had prior to operation and the pain, and then of course he didn't get the stability because of this heavy weight and others, but he was painless. So that's one advantage that we have. So joint को बदनाम न करो. Joint surgery बहुत अच्छी surgery है, और this is a surgery which the surgeon should not sell. The patient must buy. This is very important. Patient should buy the surgery, not the surgeon should sell. क्योंकि अगर पेशेंट को बहुत तकलीफ है, ऑस्टियोआर्थराइटिस इतना है कि वो कुछ नहीं कर सकता, डायरेक्ट नहीं कर सकता है, अगर उसमें से वो अल्टीमेटली कहता है डॉक्टर साहब कुछ करिए हमको दर्द से आराम पड़ जाएगी, तो उस सर्जरी को आप करते हो, अगर उसको 70% भी बेनिफिट होता है तो बहुत हैप्पी होता है कि हम जो जैसा थे वैसा नहीं है. लेकिन इफ़ यू डू ए सर्जरी सेलिंग इट, नहीं आप करेंगे, आप एकदम 100% ठीक हो जाए, उसको 5% भी दर्द रहेगा, ही विल बी ए हेडेक फॉर यू. सो द इम्पॉर्टेंट थिंग इज दैट डोंट सेल जॉइंट सर्जरी, let the patient buy it, and if you are a good salesman and if you have asked your patients to keep good track on it and use it properly, अच्छी गाड़ी खरीदो, अच्छे सड़क पर चलाओ, गाड़ी की longevity रहेगी, बदनाम भी नहीं होगा. Thank you very much, Dr. Ashok, and this was my comment. It's not a question or anything. Thank you very much for letting us know.
It has been very good and interesting session, and he has shown something which is very much desirable with the replacements. So I congratulate him for this, that he has shown the way, what are the requirements to achieve such function, and what the change in the model and the implants. Is there another, I think, milestone to be covered? But this is the way, I mean, to say. A little bit of this thing that yes, posterior superior coverage of the cup definitely gives added advantage on this front. But it takes a lot of courage to, I mean, allow your patients like this. And what Professor Aya and Dr. Anand Singh has said is very much relevant. Every car shows the speedometer that it will run on 220, but nobody runs on this. Thank you very much.
Thank you, sir. We would like to see the follow-up in maybe 10 years down the line in AMC 32. Thank you, sir.
Now I would like to call Dr. Ashok Singh, sir, facilitate our chairperson, sir. Sir, please.
Yes. Sir, Ashok sir, आप भी आइए। सर, भरत, आप लोग भी जाइए। फेलिसिटेट करना आप लोग आए। Yes, sir. Yes, sir, सबको ही देंगे। हम सोचे हम लेने आए हैं। नहीं, आपको देना है। चलिए एक अच्छा फोटो लगा। आपको चाहिए एक फोटो ले लीजिए। हाँ। I'm very thankful to Dr. Anand Shankar sir.
Use some like connecting.
Now we have the inauguration function, and give us 5 minutes, we'll just set up the things. And our chief guest has already arrived. He's viewing the new robotic platform, and we'll have lunch post inauguration.
Can I shut it? Can I shut it? Shut it. Or no, it's fine. नहीं. ये दिखना चाहिए. I am not visible actually. It's shutting down. Huh?
Good morning, one and all present here. I, Prerna Pratap, on the behalf of Bihar Orthopedic Association and ANUP Institute of Orthopedic Center, take the privilege to welcome you all in today AMC 2022 seminar. Welcome you all to the ancient land of Patliputra, the land which is inhabited on the banks of holy river Ganga. And definitely, I would like to mention this, it's an absolute honor, it's an absolute matter of pleasure and pride as well, because today we have such eminent guests as Dr. Santosh Kumar. He came here from Kolkata. Dr. Adarsh Annapreddy is from Hyderabad, and Dr. Bharat Singh, definitely he is president of BOA, of Bihar Orthopedic Association, and Dr. Manish Prasad, secretary of BOA, and yes, of course, Dr. Ashish. Today is really very special day और हमारे लिए बहुत ही ख़ास दिन है, और इस ख़ास मौके पर आप सभी का एक बार फिर मैं तहे दिल से मैं प्रेरणा प्रताप बहुत स्वागत करती हूँ अनुप इंस्टीट्यूट ऑफ ऑर्थोपेडिक एंड रिहैबिलिटेशन सेंटर की ओर से और बिहार ऑर्थोपेडिक एसोसिएशन की ओर से। आज का ये दिन हमारे लिए बहुत ख़ास है क्योंकि भारत में चिकित्सा जगत में ऐसा कुछ पहली बार होने जा रहा है। ये हम सभी के लिए वाकई में चकित कर देने जैसा है, और जिसके लिए निसंदेह बहुत सारा श्रेय जाता है अनुप इंस्टीट्यूट ऑफ ऑर्थोपेडिक सेंटर को और डॉक्टर आशीष को। पहली बार भारत में रोबोटिक सर्जरी की जा रही है, वो भी लाइव सर्जरी, जिसके लिए हमारे डॉक्टर्स भारत के कई प्रांतों से यहाँ पर आए हैं, और इसके लिए वर्चुअली भी पूरे विश्व भर से बहुत सारे डॉक्टर्स हमारे साथ जुड़ने वाले हैं। तो डेफिनेटली ये बिहार के लिए गर्व और गौरव का विषय है। और आपको बता दूं कि ये जो रोबोटिक सर्जरी की जा रही है, रोबोट्स अवेलेबल हैं और वो आप डिस्प्ले के लिए अवेलेबल हैं, आप उन्हें देख सकते हैं। और सबसे ख़ास बात ये मैं बताना चाहूँगी अनुप इंस्टीट्यूट ऑफ टेक्नोलॉजी की कि निःशुल्क पिछले 3 सालों से इस सर्जरी को किया जा रहा है और सक्सेसफुली किया जा रहा है। सबसे अगर हम बात करें, हमारा जो ये मानव शरीर है, हमारे जो ये ह्यूमन बॉडी है, उत्तक कोशिकाओं और तंत्रों से मिलकर बना है। शरीर के कई अंग हैं, हर अंग की अपनी अपनी अलग इंपॉर्टेंस है, अपनी अलग महत्व, उसकी अपनी अलग महत्ता है। लेकिन अगर हम हड्डियों की बात करें तो बिना हड्डियों के हम अपने शरीर की काया का हम अनुमान नहीं लगा सकते, हम संभव भी नहीं, ये सोच भी नहीं सकते कि हमारा शरीर खड़ा हो पाएगा। जिस प्रकार कहते हैं कि मूलभूत आवश्यकताएं हैं रोटी, कपड़ा और मकान, लेकिन ये जरूर कहना चाहूंगी हमारा स्वास्थ्य भी मूलभूत आवश्यकताओं में आता है और इन सबसे परे है। अगर 4 दीवारें खड़ी कर दी जाए और दीवारों के ऊपर छत ना हो तो आप उसे घर या मकान नहीं कह सकते। उसी प्रकार जिस प्रकार आपके शरीर के सारे अंग समान रूप से काम कर रहे हैं, लेकिन अगर आपकी हड्डियां समान रूप से काम नहीं कर रही हैं तो कोई भी मनुष्य स्वस्थ मनुष्य नहीं कहलाएगा, वो एक हेल्दी ह्यूमन बॉडी नहीं कहलाएगी और वो अपने शरीर के बदौलत कुछ भी नहीं कर सकता और वो सामान्य जीवन नहीं जी सकता। तो हड्डियों को स्वस्थ रखना, हड्डियों में किसी भी प्रकार के विकार को दूर करने की कोशिश कर रहा है अनुप इंस्टीट्यूट ऑफ टेक्नोलॉजी। और इसके लिए मैं चाहूंगी कि एक बार हम जोरदार तालियां इसके लिए, इस मुबारक मौके के लिए जोरदार तालियां होनी चाहिए, क्योंकि एक माइलस्टोन है हम सभी के लिए पूरे मेडिकल फील्ड में, चिकित्सा जगत में, क्योंकि ये देश में पहली बार ऐसा होने जा रहा है। और इसके लिए हम इनवाइट करना चाहेंगे हमारे आज के एमिनेंट गेस्ट को, हमारे साथ जो मौजूद हैं, जो कोलकाता और आंध्र प्रदेश से यहाँ आए हैं हमारे बीच, और आज के इस सेशन का शुभारंभ उनके हाथों होने वाला है। और हमारे साथ आज यहाँ पे होंगे ऑनरेबल पटना हाई कोर्ट के गेस्ट। मैं उनका बहुत बहुत स्वागत करना चाहूँगी। हमारे साथ श्री पार्थ सारथी जी हैं, ऑनरेबल हाई कोर्ट के जस्टिस। आपका मैं चाहूँगी एक बार जोरदार तालियों के साथ हम इनका स्वागत करें। मैं डॉक्टर RN सिंह सर का बहुत बहुत स्वागत करती हूँ। मैं डॉक्टर भरत सिंह आपसे भी रिक्वेस्ट करूंगी कि प्लीज काइंडली कम अप ऑन स्टेज। डॉक्टर भरत सिंह, ऑनरेबल जस्टिस पटना हाई कोर्ट श्री पार्थ सारथी जी, आई वुड लाइक टू रिक्वेस्ट यू प्लीज कम अप ऑन स्टेज। I would like to request Dr. Bharat Singh, BO President, please come up on stage. I would like to request Secretary BOA, Mr. Mahesh Prasad, kindly come up on stage. Dr. RN Singh, हमारे बिहार की शान, he is a gem. हम सभी जानते हैं, किसी परिचय के मोहताज नहीं, चेयरमैन है अनुप इंस्टीट्यूट ऑफ टेक्नोलॉजी के। और मैं डॉक्टर आशीष आपसे भी रिक्वेस्ट करूंगी कि प्लीज़ आप मंच पर आएं, अपना स्थान लें। मैं AIOR मेडिकल सुपरिटेंडेंट डॉक्टर अशोक सिंह आपसे रिक्वेस्ट करूंगी काइंडली कम अप ऑन स्टेज सर प्लीज। It's an absolute pleasure and honor for us to have you here all. Now I would like to request Dr. Ashish to felicitate all the dignitaries.
First of all, I may request Dr. R.N. Singh, my father, to kindly felicitate Parth Sarthi sir, or Honorable Justice High Court. Please.
Ladies and gentlemen, a huge round of applause for this such a lovely moment. हमारे लिए बहुत ही गर्व का विषय, पूरे बिहार और पूरे भारत के लिए ये बहुत ही गर्व का विषय और बहुत ही सुनहरा दिन, बहुत ही खूबसूरत पल। डॉक्टर R.N. सिंह सम्मानित करते हुए, स्वागत करते हुए माननीय हाई कोर्ट ऑनरेबल जस्टिस श्री पार्थ सारथी जी का स्वागत और सम्मान करते हुए आपका बहुत बहुत धन्यवाद।
May I request to felicitate Dr. Bharat sir, Dr. R.N. Singh sir, please. लेके आप ऊपर ही रहो। सर आप कर दीजिए, कोई भी भरत सर को आप कर दीजिए।
डॉक्टर R.N. सिंह स्वागत करते हुए बिहार ऑर्थोपेडिक एसोसिएशन के प्रेसिडेंट डॉक्टर भरत सिंह का स्वागत करते हुए उन्हें फ्लावर बुके और ये मोमेंटो देते हुए बहुत ही खूबसूरत मौका। मैं चाहूंगी कि तालियां बजती रहे।
May I request Dr. Ashok sir to felicitate Dr. Mahesh Prasad sir, Secretary Bihar Orthopedic Association. Big round of applause. Bihar is booming. और लास्टली मैं चाहूंगा डॉक्टर भरत सिंह सर को फेलिसिटेट कर दे, डॉक्टर R.N. सिंह सर को। Yes, may I request Dr. Mahesh sir to felicitate Dr. Ashok sir, please. Thank you.
Now I would like to request to address Dr. Ashish because it's all because of your indefatigable efforts. So Dr. Ashish, please come here and speak few words to us. Thank you so much.
Thank you, ma'am. Thank you, Chairperson sir. Thank you to one and all for making this program so far so best actually. Now, as we have already honored our guests, I would like to just briefly tell you about ANUP Master's course. ANUP Master's course we started about 4 years ago, and it was a little talk, एक छोटी सी सोच थी हमारे दिमाग में कि हम एक पटना में एक कोर्स का आयोजन करेंगे जिसमें कि हम लोग एक फोकस चीज़ पर विस्तृत रूप से जानकारी देंगे। पहले साल हमारे यहाँ पे अमेरिका, जर्मनी, इंग्लैंड, साउथ अफ्रीका से भी फैकल्टीज़ आए थे अपार्ट फ्रॉम इंडिया, और इस कोर्स को हम एक शेप दे रहे हैं। मैं बहुत आभारी हूँ आज कि इस मंच पे बहुत लोग आए हैं और यह पूरे दुनिया में स्ट्रीम हो रहा है। अनूप मास्टर्स कोर्स को ऑर्गेनाइजेशन में मैं तहे दिल से अपने टीम, ऑर्गेनाइजिंग को सेक्रेटरी, ऑर्गेनाइजिंग ईच एंड एवरी पर्सन को और सभी लोगों को धन्यवाद देना चाहूँगा जो आज इस अवसर पर यहाँ पधारे हैं। मैं यह भी कहना चाहूँगा कि यह एंड नहीं है, इसके बाद लाइव सर्जरीज हैं एंड रात में वी हैव ए गाला डिनर विद ए ग्रेट म्यूजिकल इवनिंग। सो बहुत सारे काम है। अब मैं इसके बाद मेरे पिताजी डॉक्टर आनंद सिंह को बुलाऊंगा, वो कुछ शब्द बताएं एंड टेक इट फ्रॉम हियर। धन्यवाद।
इस अनूप मास्टर्स कोर्स 2022 में आप सबों का स्वागत है। जैसा कि डॉक्टर आशीष ने कहा कि ये 4th सेशन हो रहा है हम लोग का अनूप मास्टर्स कोर्स का। जो सबसे इम्पोर्टेंट बात है कि हम जिंदगी में रोज़ कुछ नया सीखते हैं और सीखने का कोई अंत नहीं है। मेडिकल साइंस रोज़ नई नई टेक्निक्स और नए नए विचारों से आगे बढ़ रहा है और हर एक फील्ड में ट्रीटमेंट के नए आयाम मिलते आ रहे हैं और डॉक्टर्स के लिए ये बहुत ही ज़रूरी हो गया है कि अपने आप को अप टू डेट रखें। मैं केवल यही कहना चाहूँगा कि डॉक्टर्स एंड अदर प्रोफेशन में ही अंतर है कि डॉक्टर को पेशेंट के सामने एक एग्जामिनी के रूप में उसके सभी प्रश्नों का जवाब देना, उसके सभी प्रॉब्लम्स को डील करने के लिए सोचना, उसके लिए फॉर एडवोकेट का काम करना, अपोजिशन के एडवोकेट का काम करना और जज साहब के जैसा जज का भी काम करना पड़ता है। और सबसे जो ब्यूटी है कि एक डॉक्टर के साथ सबसे बड़ी प्रॉब्लम है कि वो एक वकील साहब कैसा अपने असिस्टेंट को नहीं कह सकता है कि फलाना किताब के निकाल के ले आओ, मैं देख लेता हूँ, बता देता हूँ क्लाइंट को कि कौन धारा में आपका केस मजबूत रहेगा। अगर हम डॉक्टर एक भी किताब अपने क्लिनिक में खोल के देख लें रोगी के सामने, तो रोगी चला जाएगा कि डॉक्टर साहब किताब पढ़ के इलाज करते हैं। ये हमारी विडंबना है और इसीलिए हमें बहुत ही तरीके से अपने को तैयार रखना होता है। और आज के दिन में जो डॉक्टर का सबसे बड़ा दुश्मन है उसका नाम है डॉक्टर गूगल। डॉक्टर गूगल ने एक ऐसा डिजीज प्रोड्यूस किया है, उसका नाम है इडियट सिंड्रोम। इडियट सिंड्रोम क्या है? आई स्टैंड्स फॉर इंफॉर्मेशन derived, D for derived, internet information derived for obstructing treatment, means I means information derived to obstruct treatment, that is internet of जो पढ़ कर के लोग जो आते हैं वो डॉक्टर के लिए बहुत बड़ा प्रॉब्लम होते हैं। इस सभी चीज़ों को देखते हुए हम डॉक्टरों को बहुत ही अपडेट रहना पड़ता है, क्योंकि हर एक प्रश्न का जवाब उसको देना है। अगर आप उसको नहीं भी जानते हो, अगर नहीं बताएंगे कि हाँ ऐसा चीज़ दुनिया में है, तो फिर आप पर विश्वास नहीं करेगा। तो आज के ज़माने में डॉक्टर गूगल के साथ कम्पीट करना, रोगियों की समस्याओं को दूर करना और नए नए टेक्निक के बारे में जानना, ये बहुत ज़रूरी है। इसीलिए इस तरह का कोर्स होना भी ज़रूरी है, जिसके लिए आप सभी पधारे हैं। और हम अनूप इंस्टीट्यूट ऑफ ऑर्थोपेडिक्स की तरफ से आपको एक आयाम, दैट इज़ जॉइंट रिप्लेसमेंट के बारे में, जो आज लेटेस्ट टेक्निक है दुनिया में, इसके बारे में हम लोग आपको बताने जा रहे हैं। और हमारे जितने भी सहपाठी और सहयोगी और जो हमारे कलीग डॉक्टर्स हैं जिनके पास उस सब्जेक्ट के लिए जो ज्ञान है, उसको हम आपके सामने प्रस्तुत करना चाहते हैं। यही इस कॉन्फ्रेंस का मेन महत्व है। केवल एक बात जानना है कि अगर आपके पास एक विचार है मेरे पास एक विचार है, अगर हम कहीं मिलते हैं तो हमारे पास 2 विचार हो जाते हैं। और इसीलिए इस तरह के कॉन्फ्रेंसेज में आने से हमारा अपना विचारों का आदान प्रदान हमें और ही आगे हमारे नॉलेज में वृद्धि करता है। इस मौके पर आज हमारे बीच पटना हाई कोर्ट के ऑनरेबल जज मिस्टर पार्थ सारथी जी आए हैं। मैं उनका आभार व्यक्त करता हूं कि अपने व्यस्तम समय में इस नॉन मेडिकल काम के लिए, इन्होंने नॉन जुडिशियल काम के लिए कहिए, हाँ हमारे बीच आए और इन्होंने इतना समय दिया। और मैं इनको ये भी कहना, इसलिए मैं ये लीगल और डॉक्टर्स के बारे में शुरू में बोला कि इनका जो प्रोफेशन है उससे हम लोग थोड़ा दूर हैं, क्योंकि इनके प्रोफेशन में, इनके जब ये प्रैक्टिस करते थे तो इनके चैम्बर में जाने पर कोई दीवार नहीं दिखता है, खाली किताबें दिखती है, क्योंकि सभी किताब देख करके ही क्लाइंट खुश होता है। जबकि हम डॉक्टरों के यहाँ दीवार पर किताब नहीं दिखती, बिकॉज हम किताब नहीं देख सकते। तो बहुत बहुत धन्यवाद जज साहब कि आप आज इस हमारे बीच आकर हमारे इस प्रोग्राम का शोभा बढ़ाया और हमारे इन नए डॉक्टर्स का और जो हमारे हम समकक्ष भी हैं वो लोग भी को सबका मान बढ़ाया। और आप को मैं फिर तहे दिल से पूरे अनूप इंस्टीट्यूट ऑफ ऑर्थोपेडिक्स ऑन बिहार ऑर्थोपेडिक एसोसिएशन जो हमारा पेरेंट बॉडी है उसकी तरफ से हम आपको बहुत बहुत धन्यवाद देते हैं कि आज आप आए और इस प्रोग्राम का शोभा बढ़ाए। बहुत बहुत धन्यवाद।
Thank you so much, sir. आपका बहुत बहुत आभार. And now we'll begin with our inaugural ceremony. May I now? Okay. Now I would like to request Dr. Bharat sir kindly speak few words to us.
दयास पर उपस्थित हमारे चीफ गेस्ट मिस्टर पार्थ सारथी साहब पटना हाई कोर्ट के ऑनरेबल जस्टिस हैं और हमारे बीओए के पास्ट प्रेसिडेंट और पैट्रन और विश्व हिंदू परिषद के अध्यक्ष डॉक्टर अशोक, डॉक्टर महेश जी बीओए सेक्रेटरी, डॉक्टर आशीष ऑर्गेनाइजिंग सेक्रेटरी इस कॉन्फ्रेंस के। सबसे पहले तो मैं धन्यवाद डॉक्टर आशीष को दूंगा कि ये 4 साल से लगातार इस कोर्स को करते आ रहे हैं और डे वाइज डे ये प्रोग्रेस करते जा रहा है। जैसा सर ने अभी हम लोग को बताया, डॉक्टर आरन सिंह ने, कि किसी नया चीज़ को एडेप्ट करने में हम लोग को बहुत समय लगता है और कोई करना नहीं चाहता है। हम लोग जब पढ़ते थे जिस ज़माने में 1-2 सर्जरी देख कर आए थे और आज कितनी सर्जरी है कोई एक आदमी नहीं कर सकता है। सब स्पेशलिटीज पर सब स्पेशलिटीज होते चली जा रही हैं, लेकिन ये नए रोबोटिक सर्जरी को एडॉप्ट करना, पटना में लाना, ये मामूली काम नहीं है। शायद ही कोई डेयर करेगा और एक डॉक्टर आशीष इसको लाकर हम लोग को इस चीज़ से अवगत करा रहे हैं, इसके लिए मैं उनको बहुत धन्यवाद दे रहा हूँ। और ये बीओए के का ही एक पार्ट है, क्योंकि हम सभी बीओए के मेंबर हैं, इसलिए हम कोई प्रोग्राम करते हैं तो बीओए के अंडर में ही करते हैं। इन्होंने हमसे अप्रोच किया, हमने कहा कि भाई आशीष आप बीओए के बैनर रखिएगा कि नहीं रखिएगा। इन्होंने कहा कि जरूर रखेंगे, क्योंकि हम लोग सभी तो बीओए के मेंबर हैं। इसलिए मैं इस बात का बहुत धन्यवाद देता हूं और मुझे बहुत खुशी है कि डे वाइज डे संख्या हम लोग की बढ़ती जा रही है और इस नए चीज़ से सीखने का और नई चीज़ को एडॉप्ट करने का हम लोग को समय मिलते जा रहा है। धन्यवाद।
Thank you so much, sir. Now, for address, I would like to invite Dr. Mahesh, sir. Sir, please come up on here.
Thank you, Ashish. Our honorable chief guest, Parth Sarthi, sir, our patron of Bihar Orthopedic Association, Dr. Aran Singh, sir, Honorable President, Professor Bharat Singh, dear Ashish and Ashok Singh on the dais sitting, our postgraduate student, all the members of Bihar Orthopedic Association and all faculty coming across the country and of course our state. On behalf of Bihar Orthopedic Association, I welcome you all and pay my sincere gratitude to all of them. Bihar Orthopedic Association has very much vast course of this type of academic activity running across the state or district level. I must congratulate Dr. Ashish, who has done a wonderful event on robotic activity in our surgical skill. Nowadays, the era of innovation, tools and skill. These three things nowadays in orthopedic science has a great role in advancement. Our new postgraduate students are trying to do some new things, and I think this course will help a lot to all of you. Robotic surgery is a new thing in the field of orthopedics. And I think a couple of years, I think it started from 4 years back, ANUP Master Course has created a milestone history in the state. And of course, Bihar Orthopedic Association has done associated with this, and we benefited a lot from this. I don't know much about the robotic surgery, but Dr. Ashish has done for last 4 years, and he has a tremendous experience about the robotic surgery. He has done total hip replacement, total knee replacement, and we all know his experience about all the members of our association. And I thank to Dr. Ashish especially for this kind of activity. And lot of academic activity from Bihar Orthopedic Association has come in pipeline. Recently, we have getting IFASCON 2025 in Patna, recently 1 day back in Goa. And one event on Rajgir, NELSCON. Dr. Maurya sir has taken part in that NELSCON also. So we all get together to do a lot of academic activity from the Bihar Orthopedic Association, and all the members are coming together to do and run this sort of course for our association and of course our young orthopedic surgeon. Robotic surgery nowadays is very much advanced, and in Patna we are privileged do ANUP master course, and we lot of benefited from this course, and we looking forward to such more academic activity from ANUP master course. Dr. Ashish has done this wonderful job. Thank you, Ashish. And on behalf of Bihar Orthopedic Association, I personally appeal all the young orthopedic surgeons, especially postgraduate, to take part in this type of academic activity and take benefited from that. Thank you very much.
Thank you so much, sir. To give away the special address, now I would like to invite Shri Parth Sarthiji, Honorable Chief Justice, Honorable Justice, High Court. Sir, please.
Respected Dr. R.N. Singh, Dr. Bharat Singh, President, Bihar Orthopedic Association, Dr. Ashish Singh, Organizing Chairman, and entire team of ANUP Masters course, distinguished guests on and off the dais, members of the faculty and participants who are present here or have joined online, ladies and gentlemen. Thank you, Dr. Ashish, for having invited me to inaugurate and be a part of this function. But frankly speaking, I do not find myself to be an appropriate person to speak on the subject. At best, the only connection which I may have had with the subject was severed only about 35 years ago. And the only claim that I have today is not confusing humorous with the word humor. However, I am fully conscious of the fact that organization of these courses not only lead to having greater experience, exchange of ideas, broadening of one's horizon, becoming aware of the latest procedures, not just in theory, but seeing their live performance, and all this leading to benefit of patients at large. Thus, may I take this opportunity of congratulating the entire team of the ANUP Masters course under the guidance of the patron, Revered Dr. Aryan Singh, for having organized this event under the aegis of the Bihar Orthopedic Association. Wishing you all success in your present endeavor and also in future. Thank you.
Thank you so much, sir. Now we will begin with our inaugural ceremony. May I now request all the dignitaries to inaugurate this day with lighting of the lamp ceremony. हमारे हिंदू धर्म की ये परंपरा है कि हम किसी भी कार्य की शुरुआत उसका शुभारंभ दीप प्रज्वलित करके करते हैं और आज AMC 2022 का शुभारंभ हमारे आज के माननीय मुख्य अतिथि ऑनरेबल जस्टिस हाई कोर्ट श्री पार्थसारथी जी, डॉक्टर आरएन सिंह जी, डॉक्टर आशीष, डॉक्टर भरत सिंह प्रेसिडेंट BOA, डॉक्टर महेश प्रसाद जी सेक्रेटरी BOA, आपके द्वारा दीप प्रज्वलित और इसी के साथ हम स्वस्थ भारत की कामना करते हैं। आप सभी का बहुत बहुत आभार। और अब मैं आप सभी से रिक्वेस्ट करती हूं कि आप अपनी अपनी जगह पर अपने अपने स्थान पर आप खड़े हो जाएं नेशनल एंथम के लिए। आई वुड रिक्वेस्ट यू ऑल काइंडली स्टैंड अप एट योर प्लेस फॉर नेशनल एंथम।
जनगण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे तव शुभ आशीष मागे, गाहे तव जय गाथा, जन गण मंगल दायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
जय जय जय। And now I would like to dedicate my two lines for all of you. आप तमाम डॉक्टर्स के लिए मेरी दो पंक्तियां। आप ही रहीम हैं, आप ही हैं राम, देश के ओ कर्मवीरों आपको सलाम। जी हाँ, आपके बिना हम स्वस्थ भारत की या फिर हम उन्नत भारत की कल्पना नहीं कर सकते। तो थैंक्स टू आशीष, थैंक्स टू डॉक्टर आशीष। इट्स ओवर टू यू।
थैंक यू मैम। सर को ऊपर लंच के लिए ले जाना फीमेल वन में। We'll take a break for the lunch, which should be pre-followed by the exhibition stalls. Everybody should visit the exhibition stalls, and I will be performing a live surgery post-lunch session. So you have the lunch break. The lunch is being served in Kesaria Hall, and for the faculty, it's a premiere on the 5th floor, I believe. Our support staff and our team will guide you where to go. And for the stall people, the company people, the lunch is at Bollywood Treat. So I would like to invite everybody for lunch, and please do visit the stalls because they are here to show the latest medicines and the stuff available. Thanks a lot.
हेलो 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 चेक हेलो चेक આવે મારો અવાજ આવે જીતુ हेलो हेलो चेक મારો આવે ઓકે તું બોલ માઇક માં કઈ
हेलो हेलो टेस्ट 1 2 टेस्ट
ઓકે થોડુંક દૂર જઈને કેમ તેમ તે ચેક કર બોલતો રહે નોર્મલ વાત કરતા રહો वीडियो स्क्रीन भी चेंज करना है
हाँ हाँ
नहीं और तो हाँ ऊपर नहीं रोबोट नहीं
हेलो शशि आવો
હા તો જે કેમેરા પાસે આવ ને જે બોલતો હોય તે હા ને 1 2 3 કર એટલે
हाँ 1 2 3 चेक टेस्ट 1 2
એક મિનિટ આરામથી ફિંગર બતાવજે એટલે 1 બોલે ત્યારે
1
હા
2
હા
3
ઓકે
4
ઓકે
5
ઓકે
5
હા
4 3 2
ઓકે
1
ઓકે ઓકે ठीक છે माइक म्यूट कर दे चलसे
चलसे ना डन ना
वापस हाँ
बोल रहने दीजिए
हाँ ठीक है अभी स्क्रीन पे रहेगा आप यहाँ से म्यूट बंद कर दो
हम म्यूट कर दे रहे लंच करके आइए अब लंच करके आइए
few mouth-watering lunch has been done and all the stomach has been full. So to break your sleep and everything, we are going with a few interesting cases that will be presented by Dr. Shashikant sir and Dr. Vivek Shankar sir. I think Dr. Gyan Ranjan, he is not here. So, sir, kindly please come here, sir, and please discuss with your cases, sir. नहीं नहीं है नहीं नहीं वो तो ऑपरेशन वाला है ना नहीं नहीं सर का अपना अलग केसेस होगा 4 केसेस कहाँ हैं नहीं लाए मुझे बोला था कि यही देखेंगे अच्छा उसी को लगा दीजिए और यू वांट मी टू गेट माय केसेस आई कैन गेट द केसेस इन 2 minutes प्लीज 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 डू इट आई विल डू इट
Why during lecture? During lecture, so he would be seeing the surgery and also. That's what Purushottam said.
Okay. He will be viewing the surgery, and after surgery he has a talk.
During the surgery.
After surgery he has a talk too.
So while the surgery is on, he would be on the screen also.
Okay.
Only the discussion is the 20 minutes जाएगा नहीं ऐसा. Please call Dr. Shashikant Kumar.
So we will waiting for the cases. Dr. Vivek Shankar is coming with the cases.
Mac and converter cable.
Good afternoon in the post-lunch session. May I request Dr. Dhillon sir, Dr. Ramakant and Dr. Sudeep Kumar to please come on stage for the discussion. So this is a case which came about 2 months back. He's a 58-year-old male presented with pain over left hip region and groin, difficulty in ambulation for last 3 months. There is a history of neck of femur fracture with hemi replacement hip arthroplasty done outside about 3 years back. Now the local examination skin condition was normal and this scar was healed. Local temperature was normal, range of motion was normal, there was no DNVD and other joints were normal. So we got this X-ray, this is the immediate post-op 3 years back X-ray. So this appears to be a bipolar good joint done somewhere outside. Now after a symptom-free period of about 2 years, the patient has developed anterior thigh and groin pain. ESR CRP which was done sequentially was within normal limits, and we got a bone scan done which was suggestive of aseptic loosening of the stapler component. We did a hip arthro aspiration which was dry. So this is the recent X-ray of post 3 years post hemi arthroplasty. Dr. Ramakant, what would you suggest to be done in this?
Hello. I think this is 53-year-old lady, right?
Yes.
So this is 58.
The 58-year-old, the 3-year-old, yes.
Yeah, so this is too early for a bipolar. I mean,
that is true. That is correct.
So you are saying that you have ruled out all, infection. You have done bone scan, so it's a aseptic
So initially the
loosening,
ESR and CRP were within normal limits. We did a sequential ESR CRP and we have checked for the last years the patient has on and off pain in the anterior groin pain, but he was by and large symptom free for about 2 years, and post 2 years, like from 2019 to 2021 he was okay. Between 2021 and 2022 he had developed this pain. And from outside they have got ESR CRP which was normal, skin was normal, there was no range in temperature, the range of movement was okay.
But she's having pain.
But she's having pain.
So if you have ruled out infection,
we've got a bone scan done which showed that there is an aseptic loosening, and we did a aspiration from the hip which was dry.
okay. So once we have ruled out all aspects of infection, then I think it's a simple case of acetabular erosion or acetabular loosening. So we have to revise the hip.
Yeah. Basically, see, from my point of view, I'll just not rule out infection as of now. So looking at the lysis which is happening, either it is the cartilage which is getting lysed because of the bipolar being done too early and patient may be very highly mobile and active. But still, and there is a lesion at the, just at see lesser trochanter, there is a lesion as well. You got a pointer. I think the bone is not looking great there as well. Though stem has not subsided, I think, if I'm 100% not sure, but then the last X-ray didn't show any subsidence of the stem. Though there is some lysis here, if you can see on the other view, but then probably I'll not rule out the infection. I'll keep my mind open for a 2-stage revision. Probably I'll not go for a 1-stage revision. Definitely this needs a revision, okay?
Dr. Lilo, sir, what's your take on this?
One should take perioperative samples also if there is a infection. If on the naked eye there is no infection, even then one should take sample from the acetabular floor just to rule out any
Yes, so the house says that we need to operate this patient, but you have to keep in mind that intraoperatively finding will determine the kind of operative intervention that
but
you will perform.
the intraoperative finding is very subjective. So you have to be very, very careful when you're going. If you go with a very close mind, so you have to actually go with a very open mind and with a fixed plan. You just cannot go that I'm going to do a one-stage revision. Probably I'll never go with this. I'll definitely go with a two-stage plan, because no matter what you do, you can always, and you never know that patient may be allergic to the metal.
Absolutely.
You never know. So you may need to test that as well. And if you put in the next stem, or suppose this seems to like a coral stem, which is well-fixed stem, why there is a lysis at the lesser trochanter lesion? So probably for me.
So, yes, so if you look at this X-ray, the superior margin, the weight-bearing margin of the acetabulum looks, there is a big lysis over there. And probably this is the cause of the pain in this patient. There is, of course, there is a little bit of lysis in the greater trochanteric area also. So that's another area of contention. So we did a diagnosis of aseptic loosening in this patient, and could be a infected bipolar. So the treatment plan, we decided we either will go do a single stage or a two-stage revision surgery. So that's the area which was contentious in terms of the lysis and which was causing the pain. So intraoperatively we did go and we found that there was plurulent discharge in the area of the acetabulum. It was absolutely plurulent, but the problem was the stem was pretty well fitted, so it was very difficult to take out the stem. And we did a thorough debridement with betadine and saline wash, and then we put an AMP antibiotic imperimental cement spacer in this patient. So this is the post-op we did in this case, and we plan to do a follow up this patient further. So next patient is another patient, which is the 48-year-old male patient presented with pain over right hip region for 1 year. First discharge from right hip region for 1 year, and there is a limp and shortening of the right lower limb. There is a past history of 1 year back. He had a acetabular fracture, and for which a THA was done somewhere else. So on examination, this patient had discharging sinus, local temperature was raised, all signs of infection was present. His movements was restricted with flexion 10 to 80 degree, extension was completely absent, internal rotation was absent, external rotation was 10 degree, abduction, reduction 10 degree each. Limb was approximately 2 centimeters shortened, and there was no DNVD. So we did an ESR and CRP, total WBC count which was raised, serum electrolyte was normal. We sent a pus culture which showed growth sensitive to piperacillin, tazobactam, cephalosporin, sulbactam and meropenem. Now this is the X-ray. Dr. Dhillon sir, your take on this.
This is very difficult to take out the implant. Yeah. So first is challenge to take out the implant.
You may have to plan, go anterior. Actually, intrapelvic approach need to be done, because to pull this out in this case may look easy on the X-ray, but I'll tell you, we have done that once and it's not easy. So we have to open it anterior, and we have to take out the implant, the head part and the cup part from inside, because the more you try, the more damage to the central part you will do. So first taking out the implant, of course it's going to be a two-stage and other than X, Y, Z after that, but first is taking out the implant. You have to be inside. And
so I must tell you this, that we did not get anything more than an X-ray from the previous records. So this was the only X-ray, the recent X-ray that we got, and this is the only record that was available to the patient.
Absolutely fine. See, everything is clear that you have to do something for this patient, and for doing anything, you have to take out the implant, isn't it? So you have to take out the, what I'm trying to tell you is that taking out the implant, suppose it was done from a posterior approach, it's not be easy to take out the acetabulum parts. You have to go intrapelvic.
So?
Sorry?
Why do you think so?
See, it is inside, okay? It's like and everything will be contracted, and you just cannot pull everything out. And you can damage actually more while pulling it out, neurovascular and everything, than just going intrapelvic and taking out the everything very calmly and quietly. So,
I mean, certainly in this case you have to involve a pelvic surgeon and general surgeon. I mean, It's not very easy to remove the implant, and there will be lots of adhesion inside the pelvis. So the priority here is implant removal. Then it can be managed as a, stage-wise revision THR.
Okay, so any investigation, further investigation you would suggest before, in the pre-op planning?
I mean, you should get a contrast CT done to see if there is anything, any involvement of, how close is this with the neurovascular bundles, how thin your artery is.
You want to say CT angio?
CT angiography or contrast CT, just to see how
yes.
close you are, where actually you're going, where your screws are. So that is important. It may be rotated and just hitting. So our pseudoaneurysm might have been formed. So you have to be very close when you're pulling these implants out. So get a CT angio done.
Yes. So this is a 1-year-old history, and the patient already had this implant in situ, and we did not know when this fracture was happened. And if you notice this is not a bone. This is a mesh cage somebody has put to cover the floor. So, and that has migrated inside the pelvis, and taking it out, because in 1 year the mesh, we don't know what kind of addition the mesh have caused at that point of time with the screws inside, and what the screws, positioning of the screws in one of the screws looks like it is inside the bone. So taking it out would be another difficult part. Now taking the hip, dislocating the hip was another challenge for us, but because the patient had infection, it was loose and we could dislocate the hip in one go. But we, absolutely right, we did got the CT angio done to look for the addition, and then we found out that the superior gluteal artery is just next to one of the screws. So we were very, askance about the approach, whether to go in and do a posterior approach or go and do an anterior approach first and dissect the complete wound and then take the implant out. But we finally decided to go to the posterior approach. This is the CT film, CT angio films. I am sure that you would be able to appreciate the kind of mesh over here, which is there, which was not very evident on the X-ray. So you see this is the mesh. So we got the CT angio done, and 1 day prior to the surgery, we got the embolization of the superior gluteal vessels. And what we did is we dislocated the hip joint, as Dr. Sudeep sir said, and because it was it was loose because of the infection, we put 2 cockers and held the cup of the acetabulum, and we made multiple drills in the insert. So if you make multiple drills, the insert will come out, and then you can take the insert out. The difficult part was with finger we tried to dissect, and we were lucky enough to take the mesh and the screws out. So, and then we did this first stage surgery in this. So the take-home message is any revision surgery or any infected, it looks like non-infected, but you have to always keep in mind that you may have to do a first stage, and not only that, you have gone to the surgery room and then you have to do a complete revision on that table only.
Did you fracture the GT while pulling? This wiring is for what? GT fracture?
Okay, so when we were taking out the stem, there was a fracture of the greater trochanter. We did the circlage for that.
You did not use any intrapelvic approach. You just pulled the implant from posterior.
No, we did not go ahead. We were lucky because for the stem we did not have to go to the posterior.
Options have to be there.
Absolutely, we were absolutely ready for that. That's it. Thank you. Thank you, sir.
We are still waiting for the confirmation from the live surgery for the OT. So, yeah. Do we get any confirmation from the OT? No, what's the confirmation there?
हाँ किधर से?
এটা আসছে
सारे वो नए है ना?
Dr. Purushottam, Dr. Ashish from the OT.
Yes, sir.
So are you ready with that? We can start with the session.
2 minutes. 2 minutes will be ready. In the meantime, I can discuss the case.
Yes, sir. Case, PPT. This is.
So I think I should discuss the case in the meantime.
Yes, sir. And one more thing, sir.
Yes, sir.
We would like to, on the behalf of AMC, I would like to invite Dr. Frederick Picard, sir, for during the live surgery, and he has a talk also after the live surgery. So kindly connect Dr. Frederick Picard, sir.
Yeah, yeah.
And sir, we are ready with the case as per your instruction. Dr. Frederick Picard, sir, kindly unmute yourself, sir.
Yes, good afternoon, everyone. It's a pleasure to be with you.
Welcome to ANUP Master Course, sir. Sir, Dr. Ashish from OT, sir.
Yes. 5 minutes, sir.
Oh, okay, sir. Okay, sir. We will wait, sir. Till the OT starts, I would like to call all the moderators. Dr. Ramakant, sir. Dr. Sudeep, sir. Dr. Amulya, sir. And Dr. Mandeep, sir. So kindly join with the live surgery, sir. Dr. Mandeep, sir. Sir. Dr. Dilno, sir. Please.
Sir, may I start with the demonstration of the case?
Yes, sir. Yes, sir. We are ready, sir.
So first one second. First we have to get acquainted with the OT setup. So, yes. First of all, I'd like to introduce my team. On the head end, I have Dr. Annu Narayan ma'am, our chief anesthetist and chief intensivist and consultant anesthetist, Dr. Annu Narayan ma'am. Then on my assistant side is Dr. Purushottam. On my ORP side is Shailesh. And at this point of time, we are configuring the robot. So first it has to be haptically configured. So I watched in first. Actually, it takes about 5 minutes to do all these things. So in the meantime, I will show you the case. So we have a lady who is round about 23 years lady. She has bilateral avian, very severe pain, and we did her left knee hip replacement earlier. And we are planned for the right THR schedule today. So I'll get back to the X-rays. If you can see the X-rays, dikh sakta hai? Are you all seeing the pre-op X-rays?
Yes, Ashish. Can you hear me? Sudeep here.
Yes. Sudeep sir, can you see the screen of the computer?
Not yet. I think they're rotating the camera. Just let you know when the screen is visible. We're just seeing this.
1 second.
Pulse.
Okay.
Yeah, now it's visible, Ashish. Yes.
So now we have done the left hip and right side we have to do. So 23 lady with avian and we are doing her lip. So let us split what we have to plan. So number one, we see the X-rays and mark the lesser trochanter and take the leg length. and then we go to the CT planning of the cup. So we go to the cup. So this is the cup where we want to place. So we can see the planning on all the aspects like 3D. If you want to suppose increase the antiversion, so we increase it to 19. So in my opinion, the cup position should be based at the teardrop and it should be fully covered. So I have kept it 19, not 20. And presently the cup inclination is at 40 degrees, 19 degrees, and you can see the CT scan. If we want to take the lateralization, so in millimeter we can increase, but I have just kept it, we'll take it back. You can show how the lateralization is done. So you're getting it. So basically, as I told you in the morning, planning to fail. Failing to plan is planning to fail. So here we plan the cup on a CT scan. And now we will, once we plan, we also see the spinopelvic dysfunction. So in this case, we had about, there is no discrepancy, less than 13 degrees in sitting and standing x-rays of the pelvis lateral view. So we have planned the cup at 18 to 19 degrees of antiversion and inclination of 40 degrees. And are you happy with the plan? Till now, we'll show the post-op x-rays.
One thing, Ashish, just let me know ki what you have said that initially is about 18 degree, you have shifted it to 19 degree. So are you deviating what was told to you by the CT scan? Are you deviating from that 1 degree on your own? Is it the right thing to right approach?
The plan gets segmented in America.
Yeah.
And we have to reconsider the plan ourselves.
Okay.
So actually, with the newer literature, there is no exact target antiversion and inclination angle. So nowadays, with the latest papers, Mr. Jabrek, MD has said, and many papers from America, there is no target zone. We aim for 40-20, but there is another school of thought that we should be parallel to TAL. So according to Archibald and al., TAL is at 23 degrees, but then why we are on 20 degrees? And another school of thought is that cup should be optimally covered. So every patient has variation. And if we focus on the Archibald study, 1000 hips, MR angiogram done, he sold MR arthrogram done, there is a variation, but roughly 23 degrees. But on the robotic platform, we see adequately how the cup is placed and then we plan and execute it. So on the table, you can see, you have any questions in this planning part?
No, you go ahead. Just one more thing on the left side, when it was operated, because we can see the staples.
7 days ago.
Right.
A week ago.
Right.
So I would be operating on the head end. Am I happy to go, ma'am? So we do a time check, patient confirmed, X-rays on, everything is fine. And the robot does not proceed with the time check. So that's another point. So now you can see one pelvic array being placed here. So this is the transmitter which relays system to the computer. So you can see very well that the pelvic array is on the iliac crest. So I'll show you how we go about it and do it. All right. Just we are calibrating this, the startup, we have to make sure that it is in range. Camera mein aa raha hai, wo dikhna chahiye.
Dr. Ashish.
Now we are good to go. So first step is to tighten, because there is a saying garbage in is garbage out. So registration and tightening of this pin is very important. You can see 2 pins on the iliac crest and which is well being tightened. Now for the beginners and everybody, to do a hip with anterolateral and posterior approach, what I do is palpate the GT. So now GT is palpated by both your fingers and I lift the GT, the leg, to see the tip of the GT. So this is the superior part of the GT. This is the anterior part. So I have put mark here and 4 fingers this side, 4 fingers this side. So roughly incision will be this much. And I have marked here just because your incision should be in line with the shaft of the femur. So chairperson sir, Sudeep sir, may I start please?
Yes. Dr. Ashish, one question about the timing of CT scan.
It should be done within 6 weeks.
No. You are going to do operate on the both the sides. You have got CT scan on both the sides at one time, or after
sir.
operating one and then for the second?
Sir, thank you for asking this question. Sir, ideally we should do one hip, then take the CT scan and then plan it according to the contralateral hip. So this CT scan was done again 2 days ago, and then we are trying to match it with the opposite pair.
Okay, thank you.
Thank you, sir. So I am starting, sir. So you'll have some bleeders here. We don't need to worry. These are all medical bleeding. So this will just stop in a wee while. Carry on. We should hemostasis should be done, because ultimately these will collect and you'll have large volume of blood loss. So now after this, one knife again, please. I'll try to see the TFL. Genders. So now I've reached the TFL. At this juncture, I use the periosteum and erase the fat from the anterior and the posterior part. Now the incision in the beginning should not be very big, because apart from everything done, you might go wrong in judging the greater trochanter. So now, so far clear, everybody clear, any issues? So now I will take the second knife and take the TFL. Whenever you are cutting the TFL, you will have a gritty sensation. So this is very important, because you feel the gritty sensation, so you are there on the right track. And with this, I lift the leg, please, and expose the part of the TFL. So now I have exposed the part of the TFL. Now, is everything clear up till now, sir?
Yes, Ashish, it's clear. So
Yes,
your
sir.
left side is the head end and your right side is the foot end.
Yes, sir. My left side is the head.
Yeah.
I place the GT after lifting the knee, because it is the TFL becomes lax, and I place one Chanle. So now at this juncture, you see that the skin is tight. So what I will do, I will release the skin, because skin should never be tight, and it should be a genderless incision. Incision does not matter, it has to be genderless, because you have to get there. So I have increased the skin. Now, if you see it by zooming out, I will ask my assistant to hold the leg in 45 degrees, and I can see some fat here. I will clean it up in a good way. So here there is a trick. Wherever there is a fat, this means that there is a sciatic nerve nearby. Yes. One thing which I have to do here now, in robotic, is put a checkpoint. So we put a checkpoint, that I will explain why do we put a checkpoint, because the robot needs a permanent landmark on the acetabulum and at the GT, so that we can, and then we take the leg length discrepancy. So here, can you zoom out? So now I take a leg length and verify the checkpoint. Capture, please. So this is not a crude method of doing, we are actually calculating what we want. So now I'll ask my assistant to lift the leg for a while. I'll take a forceps and the cautery, and I'll generously just lightly do like this. One time. I do it this way. There are many ways of doing all these. Try tetra, please. So with the dry tetra, the fats can be erased very well. And there are some branches of blood vessels here for the short external rotators. So here, by going down, you will be able to see the short external rotators, and the best thing is to look for the piriformis. Now here I will tell you, there are two options. You can put a Langenbach's at the abductor and take it back, or you can put a Homan. So now, may I request Sharatao to be focused here. So you see here, the short glistening structure, piriformis is somewhere here. I will take a cautery and show it to you. So for the beginners, piriformis is here, and I take a tie here. Are you able to see everything crystal clear?
Ashish, just that the camera is coming from your left shoulder, if it can come from your right shoulder, if it is possible. Otherwise, it's clear. But if it can come from your right shoulder, it will be better.
Sir.
Yeah, okay.
So give it 2 minutes. Actually, now we'll just shift. Once the head is dislocated, we will just, it will be fine. 2 minutes, because now here I have taken the capsule and the short external rotators. Suck, please. Keeping my finger down, because the sciatic nerve is somewhere. I don't look for sciatic nerve, and I slowly. 1 minute, they are changing the picture. Yeah, 1 minute they will take, but in the meantime I'll just do the, because it is a surgical procedure. We have to. Check it in there, push it. Take out. Is the camera set? Nag is, this is a, where is the camera? Okay, so this is a special instrument, not special, but I got it modified. There are several types of instruments. To have a look at the, it is a tight hip actually.
Ashish, we are not able to see properly. Actually, the cameraman has gone to the front side of yours. Ask him to come on your right side from behind. Yeah, that's better. Yeah, that's better.
Right.
Yeah, it's okay.
Now you see, you can see. Are you visible now?
Yeah, it's clear.
Now you should focus on the screen. The screen camera should be focused. You see the magic knife. Marking, put a mark on the LT. Approaching to the line. So that's the point where we make, so you see this. I have got the, I should be roughly there. Put a mark with the cautery. Now, everybody understood this part or not? See what I did? This is a magic knife. Yes, this is a magic knife. I mean, you have to go up and mark. So on the screen you can see I am going towards 25. Now I am in green. So that means I am roughly there. The neck cut should be from here. So I have marked it and I'll take the cut. Now when doing the cut, the foot should be facing the ceiling because it's a posterior approach. So the head is out. May I have a dissecting scissor, please? Cut. Please cut. Yes. Right. So now at this juncture, head is cut according to the plan. So now coming to acetabular exposure. Acetabular exposure is an art. So you have to hold the leg at 45 degrees, ask your assistant to take a bone hook and lift it something like this, and with the exeter or front pointed anterior retractor, I'll just clean it. There is a bleeder somewhere. Hold it. Just little bit of, yeah, there. I'm sorry there was some bleeding, but every step we are going to clean the acetabulum because we have to go inside. So this is the exeter level 1 retractor, lifting the head, and I go start. Yes. So now my anterior retractor is ready. Now after this part, we need to again clean, and I do use bit of cautery down before I put my exciter 2. Here you might find some bleeders. You have to be cautious. So I'll take exciter 2. This is exciter 2. Exciter 2. Now this I personally feel in this acetabulum, the labrum is hypertrophied, so I will remove the hypertrophied labrum and clear the exposure. Give me 2 minutes. Yeah, you can. I put a east-west or mandibular retractor on the top. So this is not, I'll expose it more and take it from there. So now, after adequate exposure, you need to take the labrum out. Taking the labrum out can be done with a knife. I prefer with a cautery, and I just go on the margin. In cases of fracture, we don't cut the anterior capsule. So we are just going, trying to take out the labrum, being very cautious and taking it from there. At this side, sometimes we require the HEMANT, and I make sure to see. Yeah, sorry. So these are the extra capsules which is coming from the posterior. I may clean it. All right. I'll give you the absolutely clear view in 2 minutes. People think that when we are doing robotic surgery, we sit in a room and the robot does. So this surgical demonstration will also make you understand that actually I am working, I am washed. You can see my hands, and you can see everybody's scrubbed. So here we are trying to clean the hypertrophied labrum and trying to do things. Now one thing is extra in a robotic platform. We have to clear the proximal part, because here we are going to put a checkpoint. May I request my assistant to please put a checkpoint on the opposite side? I am holding it. So this checkpoint is the robot that I am holding it. Shailesh, no worries. You can see how the checkpoint is put. It is self-tapping screws, it goes in. That will not come in the screw placement site. So so far, what we have done extra is put 2 checkpoints. Now I usually change my retractor here because I need a smaller retractor. May I have the smaller, and I'll reconfirm the checkpoint of the acetabulum. May I request to please confirm the checkpoint, please, capture. Verify, please. Right. So now may I request the smaller retractor, please? The smaller retractor, it's well placed now, and I'll clean it up. May I request a tetra to be here, please? So anybody having any options in seeing the acetabular view of 360 degrees, are you happy to see the exposure of the acetabulum?
Yes. Dr. Ashish, Dr. Ramakant, this side.
Yes, sir.
Does TAL have a role in this robotic surgery as a landmark?
Last month I was having a talk with Dr. Sean Toomey. Yes, TAL has a role. When we place the cup, it will be roughly parallel to the TAL. But the point is that there has been a dictum that 40-20 is the target zone. And with the advent of so many things like spinopelvic dysfunction, which is the hot topic to be discussed, we are having start registration. I will start registration and keep talking. Focus, zoom on this. So we are registering things. Now, just see here, we are registering the pelvis. Okay. So we are capturing the crest position, the articular surface, and now we'll focus, zoom here. Capture. कोई बात नहीं, zoom inside. So what we are doing is capturing or making a line diagram so that the CT is being registered with the computer, and it will verify with the patient's original CT, which has to be in the range of 0.05 mm. So now posterior part, yes please, capture, anterior, the crest. So we have to capture 19 points to make the CT scan. Okay, confirm. They say that something is uncertain, so we reconfirm it. Yes. See, now we have to verify with the on the short screen. Put the screen section on there. On the short screen, you see we are verifying with the patient's original CT scan that what we have captured is how much within the zone it is. So this is a. We'll go somewhere, yeah. So we are just confirming the patient's CT scan with what we did, and so now with the playing the Candy Crush game, we are ready to rim. Now I'll stop for a few minutes. So up till now, what we have done is we have taken the incision, put two landmarks, put this system here, and captured all the point and verified with the patient's plan, a patient's original CT. Now when I was planning, I told you the cup should be at a version of 19 degrees and the inclination we planned 40 degrees. So now we are rolling in the robot. Please show this side how we roll in the robot. And we go by single rimmer. So the rimmer size is, cup size is 48. Please note, we don't need to do multiple rimmings. But we have the options of doing multiple rimmings in robotic haptic guidance. Now we are verifying this, and one minute, can we have, I'll clean it. Now look at this step. Clearly we are going, look at the screen. We are in range. You see 58, we planned 40. Focus down, idhar mein or screen pe. Screen, yes. So roughly we are there. Roughly we are there, and we'll go. We are going in. When you see the screen, go. One second. Skin. See, now you can see that. Actually, I'll take a wash because it will be better.
Ashish, just one quick question, if you are up for it.
Yes, sir. I'm up for things.
Yeah. So in knee, you decide the cuts of Mako, like setting up 5 millimeter, 6 millimeter. How you decide the depth? How millimeter rimming will be there? So did you set the depth beforehand in the system?
Yes, sir.
Okay.
I set everything beforehand. Even if you are going to go inside, the robot will give you haptic feedback, audio-visual feedback, and it will stop.
So how much
Actually,
depth, how much reaming you have set?
Actually, I planned it on the X-ray and
All right,
the three portions of the CT scan.
Okay.
And then we planned exactly.
Yeah,
Get
so
the
just for the audience, so it is decided how much reaming will happen with the reamer, and after that, beyond that point, it will start giving you an haptic feedback that you are going deep and deep, isn't it?
It will not go. Actually,
It will not
it's
go,
like
actually it will not go, yes.
It's like the car automatic transmission, something that the speed will not increase even after that. So cup will not, ream will not go. You see some red lines. That was 0.01 mm extra that we impacted on the superlateral side.
Okay, so that's 0.01 mm extra. Okay, fair enough. Good.
Suresh, can you hold this for a while? Yeah? So I will just clear some anterior side. I see some not justified stuff, so I'll remove it. So basic fundamental is that we can't go wrong, number one. Number two, the CT scan is in front of me, the X-rays are in front of me, and even if it's 60 cup, we go with one single limb. But we should all have an understanding that if you want to go the natural way, we can go and there is no issues. There are no issues. You can go from 42 to 58. I can see the cup. It's all set. And then with the robotic arm, now you'll see what happens. Free the robotic arm, please.
Just the shape of the setup element is pristine clear, so you can go with it. Otherwise, it's a little bit of distortion, you just cannot go with that. So what was the reamer that was used, Ashish, before you bang in? 54?
I planned for 46.
46, okay. 46, okay. So you rimmed it with?
I directly rimmed 46.
46. And the cup that you're using, is it Accolade? What's that?
Yeah, Trident 2.
Trident 2,
So,
okay.
Yes, sir. So now, according to the system, we have to cover it actually, sorry. Yeah, 1 second. Yeah. Cover kar de. It's 9 mm proud, focus the screen. 5 mm proud, 4 mm proud, 3 mm proud. The voice has changed. We'll stop and see if it's fine. Actually, it has well settled. So we'll hit one. Just 1 second. It splashes on our mouth, so that's fine. 1 mm proud. So technically, 1 mm proud is fine, they say. So now the cup has been impacted, and it's done. Actually done. So I check the holes. Do I need a screw? I don't think so. I usually don't give screws, especially in young people. So I don't need screws, so it's done. Now the question is, with one I will ask, is that, focus here now. 1 minute. The cup has been implanted. You say that we planned of 4820. So how do you verify it? So let's go for it. Let's see, how do we verify it? Capture 2, 3, 4, 5. So we planned for 40 degrees and we have got 39 degrees, and 20 degrees we planned, we got 19. So take this, it's well, the cup has been placed. We have verified that the plan is inclination we planned and what we executed. We planned for 40, we got 39. We planned for 19, we got 20. So now I'm putting an MDM dual mobility liner. So we'll take a wash. So any questions up till now, sir?
Yeah, I think there is a question from audience. We'll just convey to you. He will ask you directly. Yes, please. Can we have the mic there?
तो देगा ही नहीं.
Any question from the audience? You raised your hand. Right. Okay, sir has raised a hand.
Sushil sir, Pankaj sir, Chirag sir has gone, but so see, I'll tell you, this is a very good instrument. We take out tooth from
one
this.
question. If there is a sclerotic bone, so how do you feel that your cup has impacted well?
Yeah.
Sclerotic bone.
Ashish, did you hear that question?
Yes, sir. Sir, thank you, sir. Sir, actually, I'll tell you one thing, take out. We'll take out the established detector, focus here. Focus on me. Sir, there is one good saying by Dr. He's from Australia. Doctor, supposed to come, who's the cement guy? Cemented hip replacement.
Ross Crawford.
Yes, Ross.
Yeah.
Ross actually, I know him very well. So Ross actually, he used to teach us that once you rim and suddenly it started bleeding. So that's a very good cup for cemented hip cup. Number one. Number two is that it is not according to the books. The books say that you rim 46 and you put 48. But it is always according to the feel what you get. The more hips you do, you start feeling that sometimes even after rimming 48 and remove the sclerosis, we feel after a trial that okay, 48 he would be fine, 50 nahi ja sakte. It is sclerotic, it might expand and get a fracture. So with time and tide, this will come. So I keep a cemented backup always, and when using a striker system, I use always keep a trident cup and the rim. What is the other cup? Rim fit. Other one?
Tritanium. It's a tritanium. Tritanium cup.
No. In uncemented, we have the other cup, na, same liner. PSL. Yes, sorry. I was just slipping out. It was just slipping out of the mind. See, in PSL cup, you can go for same size rimming and same size cup. It is a bit costlier, but that's a good idea to keep it at the back. So let us say my team is here. I ask them, I need a PSL. So they'll give me PSL. If I feel no, I should go for a cemented, because once you go and you feel that it is not right for uncemented, just go for cemented, you will be safe. Because cemented system is always a savior in all hip replacements. Anywhere you are stuck, cement will take you out from there. So we have placed the cup and we just have to place the stem. So according to the screen, I see that the stem size is 2. And we are using a stem and neck angle of 132 to match with the opposite size. So this is the exposure which we cut with the magic knife. Dr. Sudeep, I hope I answered the question.
Yeah.
Okay. So now exposure is very important, and all the PG students must be aware that they are putting lot of nails. So we have to expose the piriformis fossa very well, which I do. I am not a conservative surgeon that I try to save a lot of things. I need a good exposure, and see, I very cleanly, I have exposed, you can focus it here, you can see. I have exposed the greater trochanter, the piriformis fossa. Now once the piriformis fossa is exposed, I have cleaned it very well. Now for beginners, it should be very well understood that ideally what you should do, you should put a line from the center of this, going like this, so you know this is the center. For the beginners, we don't need it. And now you have broach. So you need to understand the broach, because here you won't fracture the GT, but this might you might fracture the GT. So I keep this and this same way, always. Now at this point, it is important that the leg should be facing the ceiling, and this is parallel to the ceiling, but I just did 5 degrees, 5 to 7 degrees I'm going in. So what I am trying to show that once this goes in, you cannot go like this. You have to come out straight. If you do that, you might fracture the greater trochanter, especially in patients who are old age. And then we might land up, we should always keep wires. May I have the nibbler, please? We'll take out this. I got it, fine. Now this piece of instrument is very good. But we should know how to use it. We have to enter it in the line of the canal, but the most important point is that we should keep our hand on the knee, because the knee will give you direction. You know where you have to go. This piece of instrument should not be turned 360 degrees. This is what I learned. It should go clockwise, anti-clockwise, it should drive in. You should not be very much forceful. because you will hear a crack and then you need longer stems or whatsoever the fracture pattern is. So I took out this. Now this is a piece of scoop. Using the scoop needs to be understood. How do we take out eye stream? We go inside and come out. So here also the lateral cortex, we pour just little bit. Just one scoop, not much required. In cemented, we try to make the collar. I am on size 0. The computer has shown me 1. So now lateral cortex with saving of the skin, I always try to bang with my hand, go inside first, how much it can go. Now holding the hammer is important. If you hold it from here, the impact will be high. Tuck, tuck, it will be making lot of impact. But if you have soft bone, hold it from here. So the impact would be less. So these are some precautions which I take. Try to press it laterally, very slowly. Even young lady, I am cautious. So it is going in. Actually this one is tight, but not very snugly fitting. It is coming out. So after, if you feel that it is tight, you should go out like this. Don't take it out fully, gradually go in. You know the cricketers, they keep rotating the bat. I also do like that. Go in, tuck, tuck, tuck. Go in, tuck, tuck, tuck. Next stem, please. I'm so sorry. So according to our planning, we were on a 48 cup, size 1 stem. So I think this is the, sir? No, we will go 1. This is right. This is perfect. Change it to 1. Now I would like to highlight one thing here. See, the robot will guide us accordingly the stem size. But sometimes there is a difference of 1 in 50 cases. So I planned for 2, it has come 1. Now here I can use a rimmer which is provided here aapke paas. Calca rimmer. I don't require it, but since we are on a live platform, you should know the instruments, what are being given by the company people. This is a, take it easy. This is just to show. This is a calca rimmer. Sometimes you have rough bone there, so there you go in and it will just clear off. It comes in 2 sizes. One big, dikhaiye. Lagana nahi. This is big, this is small. So these are calca rimmers. So now I am done. I will take out the stem and I have a plan of 1, 3, 2. I am using a high offset because we will see in the plan how we plan the size. Next size is 132. So I am taking a trial with the standard because minus is unfortunately available not at the moment. You can take out that. This should be a generous procedure. No? Shailesh, please come this way. There you go. See it on the computer. Okay? So now we have reduced it. So now, actually it is stable. We'll go 1 size more. Now, can you focus on the screen, please? We'll put the stem in the meantime, because stem is final. We'll not waste time, because it's not advisable. Can you please open a size 1 striker Accolade 2 uncemented stem, please? May I request a pair of gloves, please? 7.5. So we are putting, so talking is important. This is an anatomical stele metaphyseal coated. It's not accolade 2. We have to talk like this. It's metaphyseal bivalve anatomical stem which is being inserted, 132 degrees offset. High offset I'm using, and I'll just go in. I just change my gloves. Again I'm using hammer from here, not from, and go very gently, because frankly speaking things go wrong in a bit of time. I'm happy. We'll take out. We'll again give the trial. We actually calculate the things on the computer. Can you please show what will happen after we put the same 132, how much head size we put? So now focus on the screen. Okay, you want me to capture? Leg length. So now if you are focusing on the screen, Dr. Sudeep sir, Dr. Ramakant sir.
Yeah,
Yes, yes.
we are with you. Yeah, we can see that numbers coming up now.
Now change it to 127. Change it to 127. It still becomes shorter.
Yeah.
So I was trying to minimize. Now change it to 132. Give it standard size 0. If I put +3, whatever, yeah. So it becomes almost equal. So
Almost equal.
+3.
Yeah.
So we are on a city-based planning, and you see, I mean, it's like I'll show you a few things more, how we plan. Final though. We'll give the final. We don't need to try actually, because I usually don't try because you're already on the screen. We are calculating.
So you're going with +3 head?
Yes, sir.
Okay.
I will try to give the batching pair, opposite side, same. And we'll reconfirm this.
So Dr. Ashish, I mean, apart from deciding the size of the stem, robot does not have a much role in putting the stem, right? It's mainly manual.
Yes, sir. I'm very sorry.
I'm saying that apart from deciding the size of a stem, which stem size you are going to use, does the robot has any role in correcting or anti-version while putting the stem?
Actually, I am using
Mainly neck length.
version 4. And if I would have used the, one more version is there, in which enhanced version, in which we also have trackers to put on the stem while you are broaching.
Okay.
So that is also very good. But usually, frankly speaking, I'll show you something what I do. So I'm putting a dual mobility cup. In dual mobility, with the head size lesser than 52, we don't get metal head. So, I mean ceramic head. So, unfortunately for her, I have to use. But she has a demand for dual mobility. I was seeing her plan. I told her that you'll have a metal head. But child-bearing age, so here we'll gently go. Now we'll check the leg length. Say fine. See, first of all, one second. It's very important to justify what we have been doing. So what we do, how do we shucks test? Do shucks test, put 2 fingers, elevate it and check it. So shucks test has to be felt. Second is you have to do like this, feel like this. So, अब अगर पेशेंट इससे ज़्यादा ऐसे करेगा तो कोई भी कूलर निकल जाएगा. परंतु अभी फ्लेक्शन, rotations, happy, dual mobility, will go with the leg length, please. So we have again zoom out, please. Capture, please. Now. Shows. 3 shots. Put your hands on the heel and then make sure the pelvis has not drooped and feel the knees. So clinically it's fine. And I've got a good range of motion. So I think the case is done. And I will give questions. We'll discuss. How much time, ma'am? How much time?
So Dr. Ashish, I mean, do we get another data like how much you have to lateralize, how much you have to medialize, or how much is the abductor tension
Okay, sir.
from the robot here?
Sir, I will come to the plan again. So we finish the hip in 35 minutes, that is the operating time. 10 minutes will be 10, 15, 20 minutes we have time to answer all questions. So Sharadji, can you show me version 4? See, Dr. Ramakant sir and to all the people. Sir, X-ray view laiye isme. Yes. Now, if you see this X-ray, I hope it is clear. You can see that ideally we plan to put it at the teardrop. This is what we plan. If we template it on a digital template or on a local template, we plan to put it. But here in this system, we can see it on the CT scan. So go to the CT scan, this one. Yes. So here, are you happy putting this, or you wanted to be medialized a bit more? I mean, you tell me from that side.
No, I'm happy, yeah. This looks good.
You are happy?
Yes.
Sometimes we are not happy, so we lateralize things because stems are not, because Professor Beverland has also one paper that says that you should not ideally very much medialize the stem, but I think Chandler's theory is the joint reaction force will be more when you are more lateralizing the center. So we used to plan on X-ray, but now we plan on a CT. So next again, on the CT show me, on the CT again show me. Yeah, how much, this is a CT, this wale pe, is wale pe, haan. On the left side, you can see on the transverse section I am seeing it. Now you go to sagittal section. You can see, you scroll it from top to bottom. So, from top to bottom, I am seeing the containment, I am seeing its distance. We are more perfect because we are with the patient's own CT scan and we are planning on the software. And we can rotate and do anything. You can see it very well. Now you go for the next this one. Yes. Now there are two dots, green and the purple. Yeah, so this is the COR which has to be matched. Center of rotation. So I'm roughly there. So we match with this. So your question answer is you lateralize, medialize, do whatever, but your COR should be matched with the stem.
Okay.
So I'll take you from top to bottom. So I'll ask the cameraman to focus on these people. These are the Mako product specialists. What they do, how they start. First of all, they take a CT scan. Can you go to the main जो हम लोग discuss किए थे? Yes. So we load the CT scan on the computer. And then the CT scan, we mark the things on the patient's point, which we get the plan. Now, we mark the center of head. Case planning, yeah. Load pelvic CT landmarks, yeah. So from here, we mark the ASI's operative side, ASI's non-operative side, pubic tubercle, operative, sacral slope, midline, we mark everything. And then we create a model in which the implant will go. I have the option to shift it from striker accolade to accolade 2, accolade 3 is coming, it's already loaded here, trident 2 is coming, which is already loaded here. And also we'll, in near future, we'll have our systems of restoration as well. Now, once this plan is done and we match the CT scan, then I decide, okay, I want it, the version should be, either this cup should be lateralized or medialized, or it should be 42 degrees. So I decide, and I will show you how they do the virtual range of motion. Because of that, we'll show you something. We are working on version 4. So now you tell me how much flexion you want, 45 degrees. Standing flexion, I'm talking about this patient.
Okay.
So we'll put 45 here, put 45. Yeah, 45. 90 कर दीजिए, 90 तो होता ना flexion. Flexion, 45. 90. Sorry, I am actually confusing them. 90. Okay. So see, at 90 degrees, there is no impingement. I am seeing the virtual range of motion. See how we are seeing that at 90 degrees with the same planning 90 degrees, I am seeing that 90 degrees is fine. Now do 20 degrees internal rotation. Flexion, internal rotation. So let's see where. It's now internal rotation. Sudeep sir, आप लोग मेरे साथ हैं, आप समझ रहे हैं?
Yes, 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 we are listening.
Yes, so we have so much to see, and here we actually take the pelvis sitting, lateral, and standing. Close the door, please. So standing, lateral, and sitting. So we see the pelvic tilt. Now, virtual range of motion analysis, pelvic slope analysis, anterior superior iliac spine, and anterior pelvic plane analysis. We have so many things, and everything is right in front of me. So suppose we want to do anything, we change everything and take it from there. And believe me, over the past couple of years when Robert was there, everybody must be thinking that it takes lots of time. My closure is also done now, so it's roughly 45 minutes. So it actually gives you so much insight, and it will lessen the complications, because we are very sure about doing version, on this version we are doing so many things. Especially it is very good in cases of ankylosed hip. Now let us say you have an ankylosed bony hip. In bony ankylosed hip, you'll take the cut. You'll take the cut, idhar se aayega. Sorry. You will take the cut, and then you will see multiple radiographs to see where the cup should be. But here you mark, take the cut, and the reamer will go and sit there where we plan. So fortunately, there are 9 patients which are published in the SICOT journal, ankylosing patients with kyphotic deformity, bit of scoliosis as well, with fixed pelvis. So we change it. And you can see them running, they are jumping here. I mean, up till now, it's almost 1.8 years follow-up. I'll send you the papers, which has been accepted and published now. So, any more questions? I mean, please ask, sir.
Do you also send a spine data for calculating the version of the cup, version and inclination?
Yes,
like
sir.
CT scan of the spine, I mean?
Yes.
Okay.
So, as a goodwill, I mean, as a senior person, I would like everybody to start a practice, to start taking LS spine X-rays, AP lateral, and see the pelvic spine stiffness, because the spinal dynamics, spinopelvic dynamics has to be understood, because when you sit, your pelvic flexes. When you stand, when you are having a kyphotic spine, the pelvis is hyperextended. So when you will put the cup and the hip will become free, the whole ergonomic will change. So spinopelvic dysfunction, I have kept a topic tomorrow. SAHIL SANGVI from Sancheti is speaking on that.
Okay,
I would be happy to share some cases, but I'm talking on knee tomorrow. So we'll be like very much, see, we calculate the femoral anteversion, we calculate the cup anteversion, we are 1 degree, 2 degree, 0.05 mm, 0.1 mm to the zone. We see so many things. We are just having that screen. Show us that screen. In the theater, see, this is a theater, yeah. This is a theater. You can go and you see a screen which is on the front. So that is in front of the anesthetist panel. So I am seeing everything there. You see everything there. So, I mean, you are seeing live feedback. If you are getting wrong, you'll get audio-visual feedback, haptic feedback, and the robot will stop. So, I think it's a way to go ahead. Any questions from
Any question from the audience?
Other is there. I believe he must be there. Dr. Arun Singh है क्या उधर?
हाँ सर हैं.
पापा ने कुछ पूछना है मेरे से?
नहीं.
Ashish, can you hear me?
Yes, I can hear you, sir.
I have great job. Very well done, Ashish.
Frederick Pickard, sir, from Golden Jubilee National Hospital. I would like to convey my regards to Martin Sarungi, sir, Kamal Deep, sir, yourself, and every other person, everybody at Glasgow Golden Jubilee, where I learned maximum of my joint replacements. And I hope you are happy with all the stuff.
Yeah, Ashish, I've got just a quick question, because obviously you have done your simulation prior to surgery, which is excellent. But it is still a simulation. And that's why you probably remember one like Larry Dorr recommended to do the stem first, because actually you cannot really change much the stem, and then put the cup second.
Yes,
What
I will highlight it, sir, Picard sir. Sir, actually, when you are doing the enhanced version, we are doing the stem first, calculating the anti-version of the cup, because you can't change the cup actually. But in the stem, we have 5 to 15 degrees of variation. So you change the anti-version of the stem, and now we have to focus on the combined anti-version. So here, our combined anti-version is appropriately fine. It is within limit. And so the Picard sir was highlighting that we do the stem first. Because see, if you ask people, how many of us does stem first? Nobody. I mean 2%. But the robotic people, they say you have to do the stem first and then accordingly do the cup and place the stem according to the cup, because cup can't be changed. You can't change it to 25 degrees. So thank you, Dr. Picard sir, and greetings from India. So may I take a patient has been successfully done. I am very thankful for everybody, one and all, at AMC, at Maurya, and at our team here, because tomorrow we are going to have one more live knee replacement by Adarsh. He'll be doing it. I would be there as well. Same setup, we'll be acquainted and take it from there. So we'll take a good photograph, everybody turn around, and I'll take a leave from here. I need to be with you. And I thank the team MPS from Strikers. Photo. We'll just take a snap.
Yeah, thank you, Ashish. Thank you very much.
Thank you,
a
sir.
big round of applause is coming from the audience here. So I think, okay, we'll leave you to change and come back quickly. So thank you very much, and I think we'll sign off for you from the theater,
Thank
and
you,
we'll
sir.
continue here. Thank you very much. Thank you.
Pranam, sir. कितना देर बाद कितना
We will be continuing with the lectures now. There's an online lecture, total knee arthroplasty in valgus deformity, how technology may simplify us. Presenter is Dr. Frederick. He is online. He's already in line with us. We are slightly before. It was scheduled for 3:30 Indian Standard Time, and it is 3:15, but we will go ahead. Anand, is he online? Can we go ahead?
I'm
Right.
happy to.
Yeah. Dr. Frederick, can you hear us? Please unmute, Dr. Frederick, please unmute. We are not able to hear you.
Oh, okay. So
Yeah,
that's it.
yeah, we got it.
Can you hear me? Can you hear me now?
Yeah.
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 Can you hear me?
Yeah, we are able to hear you.
Listen, yes, very good. In order to avoid any glitches, because we all know that computer works very well, but sometimes it doesn't. I pre-recorded my talk, and I think the team can, if they want, launch the talk, and I'd be more than happy to reply afterwards. So is the team okay to start the video that I sent? Hello, can you hear me?
Yeah, we are able to hear you, but slides we want to adjust. He's trying to adjust. Give us some moment. Yes, Dr. Frederick, we are now able to see your slides, severe valgus knee deformity and CAS. Yeah, go ahead now.
Yeah, so is it, okay, that's the video, so you can go for it, yes, if you don't mind.
Arthroplasty center in Europe, we perform more than 4,000 joints a year. So I've been asked, working in one of the biggest arthroplasty centers, I would have loved. Hello everyone, this is a great pleasure for me to be with you today virtually, and I'd like to thank the organizing committee for inviting me, and especially Ashish and his scientific committee. I would have loved to be physically present, but I couldn't, and hopefully that will be next time. My name is Fred Picard, and I am orthopedic surgeon at the Golden Jubilee National Hospital, working in one of the biggest arthroplasty centers in Europe. We perform more than 4,000 joints a year. So I've been asked to talk about severe valgus deformity and computer-assisted technology that I have been using for the last 29 years. I'm sure you are all familiar with the goals we expect to reach after valgus knees, which are representing only 10% of total knee replacement. These knees require particular attention pre-op, clinically, but also radiologically, in order to define a clear strategy. The goals are actually always the same with knee replacement. We want to end up with a very stable, well-aligned, well-balanced knee in order to get our patients back on track to the early recovery and early rehabilitation as soon as possible. We expect a patient to be pain-free, with a good functional outcome and optimal long-term survivorship implants without any complications. I'm also certain that you are all familiar with all sorts of classifications in valgus knees. Some of you may use different ones. Here are a few ones you may have seen. Wanawat, Ludwig, Billiot, Paco. All of them are assessing actually alignment and laxity. In order to make these presentations as simple as possible, I'm going to use the Wanawat classifications. Grade 1, which represents 80% of knees with a correctable valgus and a deviation less than 10 degrees. Grade 2, 15% with an elongated MCL and values between 10 and 20 degrees, and grade 3, 5% of them with more than 20 degrees. We are going to look at the grade 2 and 3 because most of the grade 1 are actually straight forward. The questions we always ask ourselves in front of valgus knees are what sort of release we need to do in order to balance and align well our knee, and that has direct applications on not only the approach we are going to perform, but also what kind of implants we are going to use for surgery. The other questions are, do we need to start with the femoral cut first? I'm going to put in yellow what I do, which is a tibial cut first. We can debate on that roughly for hours, but as some of my old teachers used to say, when you build a house, usually you start with the basement and not with the roof, and that follows this very basic principles. The second is whether we need to do a lateral release from a medial approach or the lateral approach. On a very tight and difficult contracted knee, I'd rather prefer performing a lateral approach, and I'll show you that. Third, what do we need to do? Bone measured resection technique or gap balancing or both? And finally, what about the use of conventional instrumentations or computer robotic assisted instrumentation? There is no doubt for me that computer has an excellent and even extraordinary role in our surgical performance. The first thing I do is to use the high tibial osteotomy software. I'm lucky to have been working with this software for years, and the registration is exactly the same as the one performed with total knee replacement, except that we don't open the knee. So what it means is once we have put the trackers on the femur and the tibia, then we can start the anatomical landmarks and kinematic registrations. And once this is completed, then we have an immediate feedback on the knee alignment and laxity. So here is an example. Here it goes a little bit fast because we don't have much time. The lateral compartment is very tight, the medial is very slack, but we are going to measure that using the computer technology. Then we put the trackers on the femur, on the tibia, then complete the registration, and then we can check the alignment immediately and also the correctability of the deformity. What we had for this knee, as you see here, was 20 degrees valgus with a fixed flexion contractor of 18 degrees. And during stress test measurements, you see that the valgus could only be corrected to 6 degrees. For me, this is a definite indication for lateral approach. It is always possible to perform a medial approach in case of moderate release, and it will be then possible to release the ITB, remove the osteophytes, release the posterior capsule, correct the fixed flexion contractor, or perform sometimes the C-plasty or pie crusting, which are actually not necessary for most of these knees, which are grade 1. Again, 80% of the cases as we saw previously. If we need to perform an extensive release in grade 2 or 3, then we will need to detach the PCL, LCL, popliteus, step by step, and very exceptionally the biceps femoralis. I don't do it. Why not? Because this is the main reason of messing up with the peroneal nerve. So I don't do that because I'm using another safer technique that I will show you. The second option is to do what we call a capsule horizontal section using the Berlin technique. This is a tricky technique, so I don't really do it either because, well, especially because we are very close to the nerve, just 5 millimeters behind the capsule. However, if you have a very steady and good hands, please just do that. What I'd like to do, especially on young patients, is a vertical lateral condylar sliding osteotomy derived from Keblish Breyer technique. And finally, it is always possible to pick and to use constrained implants. The lateral approach can sort out the release and the balance in the same time. And what are the advantages? Well, a direct lateral exposure on the lateral apoplastic condyle. You have a control of the external rotation of the tibia. You can proceed for sequential release. You preserve the vascularity of the QTP mechanism. And finally, you have a direct control of the patellar tracking just in front of you. The disadvantages are that this technique is definitely more demanding, it's less routine, and there are a few tricks that I'm going to show you. So how to perform the lateral approach? The lateral approach is not a mirror image of the medial approach. There are 3 and even 4 parts in it. The first one is on the top one, and you can cut along the wide part of the VLO tendon, equivalent to the medial parapatellar approach that we would do on the VMO. But this is where the comparison with the medial approach stops. Then you have to stop on the top of the patella because you have to stay a centimeter away from the patella when cutting the lateral retinaculum. Then underneath you have to go close to the patella when releasing the synovium, all along the lateral facet of the patella. So at the end of the surgery, you'll be able to close and stitch together the retinaculum and the synovium and cover the lateral prosthesis. Then you have to pull the Hoffa ligaments and the lateral meniscus towards you in order to avoid the cutting the vascular supply that you see here on the picture from the anterior tibial artery, because if you cut that, then you may end up with a lateral necrosis of the skin just in front of the prosthesis, which is definitely not ideal. And finally, do we need to do a tibial tuberosity osteotomy? Actually, I don't do it very exceptionally. So very quick, here is a lateral approach. I just like to stitch the lateral vascular supplies. Again, it goes a little bit quick, but we don't have much time. Here is the VLO. Then you cut the retinaculum in 2 planes compared to the synovium underneath. And then you pull the fat pad towards you and attach the ITB on the girded tubercle, and you have a direct access on the lateral compartment, the lateral osteophytes, and here it is. You can even mark the white side line with your diater. So the sequences are first the tibial cut, 90 degrees to the tibial mechanical alignment, or less than 3 degrees of valgus, and around 2 or 3 degrees slope. Then you are going to measure your gaps, inflection and extension, which could be done once or twice, and then start the release process or use a more constrained implants. And then you will perform your femoral cuts, reassess, and close. So here is an example. You have here a valgus knee. We cut to 0 with respect to the mechanical axis, 7 millimeter with respect to the medial side, so very little, and 2 degrees slopes. Then we measure the distal femoral mechanical angle. It's here 8 degrees valgus because there is a lateral apoplastic condyle, which is quite common. Then we do have in extension 4 degrees gap with 20 degrees fixed flexion contractor, despite the ITB approach and the release on the lateral side. So we did a release of the ITB, we removed the osteophytes, we removed the menisci, and we removed the ACL. So the next step will be to release LCL, popliteus, and posterior capsule. You can do that sequentially, as well as the PCL, or you can use what I'm doing, which is epicondylectomy or lateral femoral epicondylostomy. One of the advantages of it is you have in the same times you can detach the LCL right here, you detach the popliteus right there, and obviously the capsule inside. Here is the vertical osteotomy on the bone model. Here is on the anatomy, and you can see that the common peroneal nerve is not too far, but it is in the same direction. And this is why I'm always worried when we start to fiddle with the horizontal capsule section. Whereas when it's vertical, you can have sliding bits of bone going down, and this is what the epicondylectomy does on the gap measurements extension. And then we need to fix temporarily this osteotomy and measure the gap in flexion. So here is, let me show you a very short video. You can see here there is a lateral lymphoblastic condyle. The Roman is put in the back. The second one is put in the back. And then that's it. The cut is done. I perform the extension gap, flexion gap. You can see the lateral condyle fixed. And then I can assess my femoral cut. The distal cut is performed. You still see very well the osteotomy on the screen. The rotation is done, and finally we can complete the femoral preparation, removing all the osteophytes in the back, in the middle, keeping the PCL. This is a cruciate retaining knee here. And finally, it is therefore possible to assess the knee with the tibial tray that I'm going to slide right here. I can remove now the pins on the tibia because the flexion gap is correct, and we can assess the knee. And you can see the knee is stable, excellent tracking, good flexion, no issues in flexion and extension. So that was the final slides for our assessment. You can see we use a size 5 knees. We had cut 3 proximals to the femur, and then we had a gap between the 3 and 4 in flexion with a rotation of 6 degrees, which was absolutely fine. And then at the end of the assessment, that's what we had, a knee with 2 degrees valgus, with a slight fixed flexion contracture of 3 degrees, which is absolutely fine. And that's the knee after surgery, and you see the screws on the lateral side of the condyle. Because it's very stable, the prosthesis covered the cement, we don't need to use most of the time any brace of any sort. So the take-home message is when you have a contractured knee in flexion and in extension, you have to assess whether it is related to the ligaments or the muscles, obviously, and then the computer can definitely help measuring and assessing the laxity and your overall alignment. You can check the patella and the tibial position, which is also extremely important to assess using the technology. Always cut minimal on the tibia first. with the meticulous lateral approach, if you do it using special medial retractor, especially on the medial side, and you can leave the knee with a possible slight residual valgus around 5 degrees. Computer-assisted technology helps to measure step by step your knee replacements. So here are a few references and some others more recent, and I thank you very much for your attention, and I'm happy to take any questions.
Thank you very much, Dr. Frederick. This was a...
Hello everyone, this is a great pleasure for me to be with you today virtually, and I'd like to thank the organizing committee for inviting me, and especially Ashish and his scientific committee. I would have loved to be physically present, but I couldn't, and hopefully...
Any questions from the house? Dr. Frederick?
Yes.
Are you, in your, this case, you went through the lateral approach. Suppose there is some planning, misplanning initially, and somebody enters through the medial approach, how he can rectify whatever he has entered already in the joint, and he is having all the problems in the lateral compartment, what all he can do?
Well, that's a good question. Obviously, when you perform a medial approach, and this is quite common, I would say, all over the planet to perform a medial approach, even with a valgus knee, and then to go step by step release. And I'm sure you have, most of the surgeons in the room have done that, starting by releasing the PCL, and then releasing the LCL, and then releasing the popliteus, and then even a little bit more the capsule, and then you have access to the posterior osteophyte. So most of the time, I must admit that it is potentially possible to do such a release, and then open the lateral compartment, because that's what you want. One of the issues I have with this is sometimes the release is so big that you end up with a lateral laxity because obviously you don't have anything keeping the lateral compartment stable. So this is why I put in this talk, for example, the use of more constrained implant. And I'm sure the safe side would be when you end up with such a degree of laxity, is probably to use a more constrained implant, which could be, for example, a TS implant, or if your valgus knee is greater than 20 degrees, and I'm sure you have seen some of this massive, valgus with 30 degrees, then some literature are recommending to perform, a hinged knee straight away. I'm not so keen to do this for younger patients, but I would think that it is a safe place to go for older patients. So to answer your question, if you do a medial approach and you want to balance your knee in valgus, it is safe to go step by step. So if you use the computer, you can see and measure your correction angles. And if you don't, then it is, you're going to have to use spacers just to see you have a right balance between the medial and the lateral compartment. That would be my answer to that.
Dr. Frederick, in the severe valgus knees that you have encountered, have you ever thought of changing the rotation of the femoral component, especially when you are using navigation? Sometimes there have been occasions in which you have to sometimes internally rotate the femur, or have you ever encountered such changes in the rotation of the femoral component, especially dealing with severe valgus knees?
Yeah, well, it's a very good question. Thank you very much. As you know, most of the severe valgus, grade 2 or 3, they do have lateral hypoplastic condyles. And so what it means is the middle condyle is big, whereas the lateral condyle is small. And that explains also usually the association with patellar maltracking. So when you compare the posterior condylar axis to the white side line, and that's the white side line I marked in this video with a W, because we can see very well the osteophytes always on the knee. You have clearly a very severely internally rotated posterior condylar axis compared to the white side line or the transepicondylar axis. So yes, we need to modify the rotation. And that is true that, for example, for a valgus knee, if you use the conventional instrumentation and you only turn the femoral components by, let's say, 3 or 4 degrees, or even, let's say 3 or 4 degrees, which is the recommendation, then the knee will still be in internal rotation compared to the transepicondylar axis, and then you keep a very large gap on the lateral compartment, which can generate instability in flexion. So this is why the rotation has to be adjusted with respect to the white side line, with respect to the transepicondylar axis, and with respect to the gaps. And this is why the computer is very useful, but if you don't use it, you have to use a spacer just to make sure you have very good gaps. Prof. Ranawat always says that it is extremely important to have a very good gap flexion in these knees, and the rotation of the femurs that is obviously crucial for that.
Thank you very much. Really enjoyed your talk, and hopefully we will be meeting soon in some other forum. Thank you very much from this side, from India. Now we are moving towards the next topic. Dr. Sudeep, Professor in Orthopedics at the All India Institute of Medical Sciences. He was talking on the severe varus knee.
Okay. Okay. Good afternoon, everyone, and thank you for letting me talk on severe varus knee deformity. I know it's a post-lunch session. Everybody's feeling a bit sleepy, but after a great talk by Dr. Prikard. So he talked about valgus knees, and varus knees is something that we encounter more often than not in our clinical practice, and especially in the state like Bihar, where those who are doing joint replacement, when you see the patients coming up, you'll see that the patients are more or less have a lot of defect, not only in the medial tibial plateau, but also in the femur side, and how to deal with it. I'll just show you some examples and how I go about with all my patients. So remember that these deformities could be intra-articular or extra-articular. Mainly these are intra-articular deformities, and mainly these are bone losses, which is happening because the patient is neglecting the disease for long time. All right, and secondary to which what happens is that there is a lot of contracture, and once you release it, there is a lot of joint laxity on the one side and a lot of contracture on the other side. So you have to be very much aware about all these things when you take on these cases, and you have to keep that in mind that one side it will be contracted, the other side it will be very lax. Okay, why I'm telling this? I'll come to it when I'll go ahead. Okay, remember that soft tissue release is very important. So MCL, capsule, pes tendon, membranosus, PCL, osteophytes. So for me, I don't do PCL retaining implants, so all these things come out, but stepwise all these things are released, assessed, and then released again. So remember that other than soft tissue, there is a lot of osteophytes and broken pieces of bone which are there that you have to be very mindful of. Those pieces or those osteophytes or the pieces from the medial tibial plateau which have been broken off over the period of time and are lying there will stretch your ligaments. So remember that. I'll show you how they affect, but remember, assess, release, assess, and then release. Don't go all out in one go. Okay, go stepwise, check, stepwise, check. All right. So these are the type of patients more often than not we arthroplasty surgeons do get in India. Okay, not only in Bihar, throughout the India, this is the common scenario. Okay, and this is what you want these patients to be at the end of the day. Right. So remember, first thing is that remove all these osteophytes. No matter how much deformity is in the tibia, it's always important to release all these deformities from the femur side, because unless until you remove these deformities from the femur, all these bones from the femoral side, you never know that how much soft tissue was stretching upon these. And you have to remember that at the end of the day, when you take out all the bones, it comes out and show you like this. Okay, these are the osteophytes just lying there in and around femur, in and around tibia. Okay, so also remember that this particular case, when the tibial tray has been made, tibial side has been made, we have noticed that, and this is one of our cases, that there is a big chunk of bone which was the broken piece of the tibia lying posterior, and the moment we released it, we got a huge amount of gap. Okay, so never do this, never prepare your tibia, never go all out before you take out all the osteophytes, all the broken pieces from all around tibia. Okay, that's very, very important. Okay, so ideal is that you take out all the pieces which have been lying there, osteophytes, bone fragments, for a long time, and then you go on preparing your tibia before you assess, trial and everything, then you go ahead. Okay. Right, the video should have worked. Okay. So remember that once you have taken your femoral cuts, the idea is to release, and you have to go all out removing all the osteophytes, and mainly these are behind the femur, that the cuts that you have taken. You have to take stepwise release, you have to go out, you have to use a curve osteotome, you can use a lamina spreader to see, but you have to go stepwise, gentle, slow, and remove all the osteophytes from the femur. I know you're all focused on tibia, but then taking all these osteophytes and broken pieces of bone from the back of the femur is equally important when you're dealing with such severe varus deformities, because bone defect management is one issue and balancing these knees is a separate issue. So you have to release everything from behind the femur. Okay. And of course, you have to remove all the bones. I have already mentioned that, and you're seeing here that before, after the tibia cut has been taken, femur cut has been taken, all these pieces that you will see now, because they are all stretching these ligaments, all are, and all mainly are posterior medial, and you have to remove them gently so that you're not damaging your MCL, you're not damaging anything more than what you need to do. And all these things are done just to balance, get your knee balanced. So and after removing all these, you can see that a severe bony defect is left there. You can see from on the, this is the left knee, and you can see that how big the defect is. The finger is just dipping in on the posterior third of the medial tibial plateau. And you have to assess these defects, and you have to go about how you want to manage these defects. And you must have a plan. But remember, before you manage, you have to release all the, you have to manage the defect, you have to release all the soft tissues, you have to take out all the bones, because you have to give a balanced knee at the end of the day, just not putting the implant. So you have to again release, assess, and then release. Okay, and these are some of the cases when you have severe bony deformities like this. You can do a step cut. In these patients, we have use a wedge. You can very well use a wedge and a rod, or if there is defects are very small, you can just use a couple of screws and build it up with cement. But then always use a rod whenever you are using screws with the cement. And these are some of the cases that you will see they're doing very well at the end of the day, but you have to manage these defects and manage all the varus and valgus deformities absolutely spot on. CT scan becomes very useful many a times. That will give you a very good picture how much the bone is there, how much the bone defect is there, how much the bone is lying behind the tibia, medial of the tibia, so that it's not mandatory for every case to have a CT scan, but it gives you a very good idea in all these patients what you are dealing with. Okay, so the more and more you do these cases, the more you'll find that okay, these things make your life very, very easy. Okay, so another patient, just intra-op picture. These are the patient walking before, and these are the common patients. It's nothing unique with us at AIIMS Patna. These are common pictures that we all orthoplasty surgeon deals with. Okay, and when you see this much is the defect, and you can make out, if I could have a pointer, that around 2. Sorry, yeah, thank you. Which one? Okay, so you can see that there is roughly around 2.5 centimeter of defect after taking a cut. You cannot take out all the defects from the tibial cut just by cutting the tibia. Okay, you have to manage these defects. You remember that because many a times while we get overzealous that okay, we'll take more cut, but that's not the right way of dealing with these defects. Okay, and there are times when the defects are just posterior, but these are the defects also need to be managed. There are times when people think that okay, we can just leave this defect because just hanging on the posterior third. No, you just cannot leave these defects like that. Okay, so you have to build this defect. If it's a small defect, you can build it up with a screw, and you can manage. But remember, whenever you're using screw, the defect has to be less than 0.5 half centimeter or more or less there, and you have to use a rod to bypass those defects. You just cannot use a screw and just do away with a screw and cement. You have to bypass because you are just loading that off from the screws. Okay, defects like these. Okay, CT scan becomes very, very important here, and you can see that defects are huge here. Okay, I'll just quickly run through the cases. So you can see around 1 and 1.8 centimeter of defect is there. And we use the distal femur or the upper femur cuts to build up these defects and graft them and then bridge it with the rod. And this is a very, very useful trick. You cannot always use a metal wedge. You have to use this tricks, but you have to remember always bridge it with this graft, because the graft is easily available from your femoral cuts, and you can always use these grafts. Very easy to use. Use the screws, but of course remember when you're using the screws, they have to just be away from the stem that you're using. Similar case, you can use the graft just rushing through the cases, and then you'll have so just another example, case example, just using the graft. Then of course the last case that I'll show is that patient has been fixed with arthritic knee, it didn't heal, patient was still in pain. So what we have to do is that we have to bypass this graft. Of course the tibial plateau is very crumbled, so this is the clinical case scenario, this is the patient, and we have to use the cone for this patient to bypass those defects, because just the rod or the graft is not going to hold up this patient, because the patient is having a defect, a serious defect just 5 centimeters down the tibial cut. And this is you can see that patient was just not having anything. We build it with the cone and the rod, and this is when putting the cone and the rod. This is last year case, this patient, and this is what comes up. So the take home message for all these defects will be that decision making radiology is very, very important. You have to keep a low threshold for getting a CT scan done to know what you're dealing with. Planning with proper implant is very important, because if you need, you can have to keep the sleeves and cones ready on the table, and the adequate coverage of the tibial tray. So you can build it up with a step wedge, or you can build it up with bone graft, but you have to bypass it with the stem. That is equally important, and then you will have a happy patient. Thank you very much for your patient listening.
Thank you, Dr. Sudeep. Any question from the audience? Any question? Oh. Dr. Sudeep,
yeah.
Question from my side.
Yeah.
I mean, what's your sequence of release on the medial side? When do you release superficial MCL? It's the initial stage or the last stage?
No, it's not really. It's slightly released in the first go before I cut the femur, because when you're taking down and I take the tibia cut always. Okay, so it's cut while after cutting, but I don't go all out and go posterior. After making the femoral cut, releasing everything from the distal femur, posterior femur, then I assess, and then all the tibial releases are done. It's never the tibia first. It's always the femur and the back side first. So it's very late. I mean, it's very late.
In severe varus knee, I mean, sometimes after
it's posterior, but remember the defects are mainly posterior. We always look upon the MCL. It's more or less anteromedial, while the contracture which has happened is mainly posterior. So I go posterior on the tibia first, and then go on come back from back to front rather than going from front to back. That is my key of releasing.
Okay. So like in severe varus deformity, I mean, sometimes even after a good balancing, there is some lateral laxity. So how much lateral laxity do you accept?
Okay, so lateral laxity, I'll say, to be very honest, we don't accept anything more than, so we want to balance in normal varus knee. So it's in a normal grade 1 or 2 OA that we do. We want the medial side to be loose and the lateral side to be tight, isn't it? Because normally our knees are like that. So we don't actually accept a lateral laxity. Okay, if at all we have to accept, it has to match with the medial laxity. We cannot overly leave the, let's say, lateral side is opening 4 mm and medial side is opening 2 mm. That's not acceptable. But then there are times when you accept 2 and 3, but not 2 and 4. It cannot be double of the medial side. Okay.
Sudeep, one question from my side. If you are using a big graft to counter that defect, any change in plan as the post-op rehabilitation is concerned, as far as the normal planning is concerned?
Yeah, so for us, no straight away full weight bearing, because all these are away from the central weight bearing area. These are either peripheral defects or the posterior defects. So, and these patients don't do very well if we go for a non-weight bearing plan. So we have always, so the idea is to use a well-fitted stem. That is the whole idea, and then full weight bearing as able next day, all these patients. Other than the valgus, only the valgus knees, or we have got some instability like patients ligament balancing is not being great, patient is having stretching up quite a lot, then we'll probably put in a long knee brace, otherwise full weight bearing straight away.
How do you manage graft and tibial bone interface?
Okay, so yeah, that's very important. So you have to roughen that, because the one that is sloped up and where you're putting the graft is very sclerotic. And if you do it a multiple drilling, then your screws will not hold. So you use a reciprocating saw. Yeah.
How you prevent migration of cement into that gap?
Sorry, how you
prevent migration of cement into that gap?
No, so you actually cannot prevent migration of the cement. You just have to use a good fitting graft over it, tight. So that is why all these X-rays you have seen, at least couple of screws have been put. Tightly compress it, but the important is that all this sclerotic area has to be nicely denuded. Otherwise, your graft will never heal up with the native bone. So it has to be denuded with a reciprocating saw. That is very important.
Thank you.
Okay, thank you.
One screw or two screw?
2 screws always. It's a big area, 2 screws front and back, or it has to be 2 screws, because the graft will fail otherwise.
In one of your cases, you have used only one.
Yeah, but it's a learning curve. Those are the older X-rays, but 2 screws mostly. Always aim for 2 screws.
Sir, I would like to invite Vinod Thakur sir for the felicitation of Sudeep sir and the chairpersons. Moving on to session 5, I would like to invite Anup sir to chair the session. Anup sir and Dr. Anand Shankar to chair the session, please. The topic is tumor around knee conservation versus mega prosthesis by Dr. VIVEK VERMA sir.
Good evening, everyone. First of all, I want to thank Dr. Ashish Singh and the organizing committee for this opportunity. So today I'm going to talk on a little different topic, that is about the reconstructions around the knee and especially for tumors. So as such, if we look at the anatomy of knee joint, it is the most common site where tumor develops, whether these are benign tumors or malignant tumors like sarcoma. And as compared to distal femur and proximal tibia, the distal femur is more common site. But the reconstruction options are much more challenging in proximal tibia, because especially in sarcomas where we have to reconstruct everything. It's not just the bone that is resected, but all the surrounding structures that provide stability, like your capsule, ACL, PCL, MCL, LCL, everything is sacrificed. So we need prostheses which give inherent stability. These are fully constrained implants. And then we also need to do proper anatomical reconstruction of soft tissues so that these implants don't go into failure. But when we talk about the reconstruction, the part which comes to our mind is about prostheses. But a lot of things are changing nowadays, and we are moving more and more towards biological reconstruction. So through this lecture, we'll go through the cases one by one. Broadly speaking, what are the factors which affect my choice of reconstruction? So though the topic is focusing on reconstruction, but I emphasize it again and again that the most important part is about the histology and the oncological resection. That is something, the first part is your oncological resection, and then comes the reconstruction. We should never compromise on the resection aspect, otherwise whatever type of reconstruction we'll do, if tumor recurs, it is going to be a failure. And especially in sarcomas, it's just not a failure of a limb salvage, but it affects the survival of the patient as well. So broadly, the tumors are divided into benign and malignant. So benign ones like your GCT or chondroblastoma, etc., which commonly affect the epiphyseal or metaphyseal region of the joint. And these tumors, our first preference is to remove it with curettage. We can go intralesional. But if we talk about sarcomas, the malignant type of tumors of the bone, we need to excise them with wide margin. So that is one part, what is the histology. Normally we have seen that the way we resect is osteoarticular, which means you cut through the joint, you cut the bone below. We'll see through various examples. But there are different type of resections. It's not just osteoarticular, it's extraarticular, intercalary, hemicortical. And third, very important, age. And because the topic is about tumors, these tumors mostly affect the common ones like osteo and Ewing sarcoma, pediatric age group, somewhere between 5 to 20, 25 years of age. So we need to consider these three factors, and of course there are many other factors like the availability of the implants, what is there, the financial, that is one of the deciding factors whether patient can afford or not. All these are other factors that govern the choice of reconstruction. Now coming to the first part, when we talk about benign tumors, like I said, the weightage is more on joint preservation. We try not to resect the joint, and especially for tumors which are around the knee, whether distal femur or proximal tibia. Let's say the most common example is giant cell tumor. We all see them in and out every day. So our first preference is that we try to do curettage with extended curettage, because even though resection gives you better oncological clearance, lesser recurrence risk, But we know that somewhere these patients are going to live lifelong, and we need to revise these implants. So always the weightage is to preserve the joint. Only the most important indication is if the articular surface is damaged, then we may have to go for a replacement. So like this, one of the example, that this is a case of giant cell tumor of distal femur. What you see here is after gross curettage, which means you use the curettes and the scoop to clear the disease. But remember, the literature what says 50 to 60% recurrence risk is because we just use we do gross curettage. We need to do extended curettage, and extended curettage is done. The most important tool is with the help of a high-speed burr. The role of adjuvants is debatable. Of course, sometimes we need, and this is just how we do an extended curettage with the high-speed burr. With the RPM is somewhere between 40,000 to 70,000. That is the ideal thing that is required to achieve this. And we can reconstruct. So this is the most common mode of reconstruction in benign tumors. It's a personal preference whether you want to use the bone graft or you want to use bone cement. In my experience, I am very much happy with bone cement because it does not only kill the tumor cells but also gives immediate stability, and we can procure it very easily. Now the challenge comes when we are dealing with the malignant type of tumors, the cancer, or the correct terminology is sarcomas around the knee. So before I move to that, the point which I was talking about, the different type of reconstructions, resections. So this was a case of sarcoma, osteosarcoma, and you see the osteoarticular, which means we resect through the joint. One cut is above with a margin, the second is through the joint. So that's osteoarticular. Sometimes we may face a situation where the tumor is involving the joint. So you can see here that the joint is involved. In these situations, we cannot go through the tumor. It's always we have to take a margin, and our resection is somewhere below and above without opening the joint. So that's called an extra articular type of resection. Sometimes the tumor leaves some space in the epiphysis and is mostly metadaphysial. So in those situations, we can do an intercalary type of resection. And if we are lucky, some low-grade type of tumors like paraosteal osteosarcoma, which may involve a particular cortex, and with the help of navigation or 3D printed zigs and implants, we can do a hemicortical type of resection, which means we preserve the joint, we remove the part of the tumor with wide margins. So let us see with some examples. So this was the case which I operated almost 5 years back. It was a case of osteosarcoma of the proximal tibia. Very important that we give neoadjuvant chemotherapy and then we plan for surgery. So this is something which I was telling, that this is an osteoarticular type of resection. We cut through the joint with a margin, and getting a wide margin is the most important aspect. We keep a 2 to 3 centimeter of bony margin and intact normal muscles all around. We never go on to the bone. We never do periosteal or subperiosteal dissection, what is taught routinely in our orthopedic practice. The reconstruction, this is a proximal tibia. This is called actually a megaprosthesis. Since we use it commonly in tumor, so it's called tumor prosthesis. The correct terminology would be megaprosthesis. So these are fully constrained types. And compared to distal femur and proximal tibia, the initial results with proximal tibia was very poor, because we know the site is such that it's directly subcutaneous, and any implant that we put there is used to fail because it got infected. There was not adequate cover. But nowadays, since I was talking about the challenges, the patellar tendon is completely off. We remove it with a margin when we excise proximal tibia. So we have hooks to cover that, but that is not which is going to give this the extensor mechanism. The most important part is using this gastroc flap. We use the gastrocnemius flap to cover the tumor, but it's not just for covering, but we have to reconstruct the patellar tendon in such a way that the knee flexure becomes a dynamic knee extensor. So this is what it looks like. And nowadays we have the availability of indigenous prosthesis. Initially it was just you say striker or debut. I don't want to criticize, but They were quite costly. Still, many of the patients could not afford them, and because of which they went ahead for amputation. But now we have indigenous implants, Indian processes, which even have rotating platform system, and they come at a very affordable price. So this is the follow-up. Normally we make the patient walk from the first post-operative day. Usually 90° of knee range of motion is permitted, and these implants also have very good survivalship. Now this is second scenario. The first was about the osteoarticular resection. So this is about extraarticular. This is also a case where there was osteosarcoma of the distal femur, but what you see here, there is a skip lesion. Mostly through the cruciates, the tumor may tend to invade the adjacent joint. So we need to plan it very well. Our MRI should show the complete extent so that we see where the tumor is involving. So in this situation, we have to resect it with margins all around. And this is what the specimen is. We have excised the joint is not open. This is the posterior aspect. You can see the entire capsule, everything is intact. And of course, in this case, this is a composite implant where we have a distal femur and as well as proximal tibia, which allows us to go ahead with a limb salvage procedure. Now the other option many a times is arthrodesis. Previously this used to be the method of reconstruction, but nowadays I hardly do arthrodesis because the implants are very much affordable, patient has a better quality of life. The arthrodesis can be used by the biological methods like using fibula graft or turnoplasty. Sometimes we use cement spacers like in this case where it was an infected implant and where you use antibiotic cement and nail plate to bridge the defect. We can even convert it into implant prosthesis later on once the infection or the disease is under control. Now this hemicortical resection, like I was saying, it has very limited indications. We need to choose our case very properly, especially in sarcomas, and mostly this is applicable in case of low-grade type of tumors where we can get a margin after resection of the tumor. So this requires a very precision planning, and in these situations the use of computer navigation or 3D printed jigs help us a lot. So this was an elderly gentleman, wrong to say elderly, actually it's just 50, and he had a low-grade periosteal chondrosarcoma of the distal femur. And we did planning with MRI and CT scan to see exactly which structures are involved. As if we compare it to the conventional treatment, probably we would have excised it with the prosthesis, but in this situation, we dissected it all around. We mapped where the tumor was exactly located. We have made the dissection all around the tumor, and then we did hemicortical. The articular surface was preserved, and we removed that part of the bone, and which we reconstructed with bone cement. So this helped him preserving his own joint, but the most important part is that the tumor should excise with wide margins. That is the most important part. The challenge comes when we have to deal with pediatric patients. It's challenging because one, the bone size is small, they have the problems of limb length discrepancy, and even after resection of the bone tumor, we have very small segment of the bone left. So all these factors, mostly these pediatric patients had to go for amputation. But now we have, like I said, with indigenous implants. So this is 8-year-old girl, and she had this osteosarcoma with pathological fracture. And this is post-chemotherapy X-ray, what you are seeing, the fracture healed. So we used the conventional implant. She was just 8-year-old. If we had used the conventional implant, then the limb length discrepancy, because of that many times people have to undergo amputation. The canal size was small, so we customized this implant, and this was an expandable implant. So the video you see that this is intraoperatively, we are expanding it. We need to keep a check about the vascularity, how it's expanding. So the picture on the right side is almost, we expand it once or twice a year after every 6 months, because as soon as there is limb discrepancy, we need to match it up. Normally this is done percutaneously on a daycare basis. There are other type of expandable implants where we may not even use screw, but it has electromagnetic coiling, but these implants are very costly. We just need to put the leg under that machine and there will be expansion of the implants. So this is now her video she sent me. So you can see this is almost 3 years follow-up after the surgery. So this was a case where she was planned for amputation somewhere else, but we were able to do a limb salvage and that could give her a very good function. So we are not able to see which side was actually operated because of the very good functions in those implants. So that was almost everything about the mechanical modes of reconstruction. That is commonly what we are used to do. But the current scenario, we are pushing the limits more towards the use of biological modes of reconstruction. That is because with the advent of chemotherapy, radiation, proper planning and management, these patients have a very good survival outcomes. If I talk about osteosarcoma or Ewing sarcoma, we talk 75 to 80% survival. So these patients are going to live long. So if we use biological reconstruction method, that once it heals, it may last lifelong. So one of the technique is that we sterilize the same cancerous bone and reimplant it, use the same cancerous bone. And that can be done with the help of radiation, which is called ECRT, extracorporeal radiotherapy, or with the help of liquid nitrogen. So I'll just show you one example. So this was a still younger boy, 7-year-old, with osteosarcoma of the proximal tibia. Now in this case, of course, expandable prosthesis is one option, but you can see the tumor, which was reaching quite, the periosteal reaction was quite down. We had a very small segment below. And if I had used expandable prosthesis, but still I know that 7 years still a very, his overall build and height was too small for this prosthesis. So we tried something which is called pedicle sterilization. We know that if you look at the previous imaging, the disease is just reaching up to the growth plate, physis. And physis is a strong barrier to the dissemination of the tumor. So we decided to take a cut through the physis. Previously, I used to do radiation. I would have cut this part and below with the margin and take it out, radiate it and put it back again. So that used to be the conventional way. But now I have moved to another technique which is called pedicle sterilization. So here, instead of taking 2 cuts, I cut just below the epiphysis, above the physis, so that we have a margin. We take the tumor, lift it off the body. You can see, but still it is inside, it's connected. This is liquid nitrogen at minus 190 degrees centigrade temperature. So this is called cryotherapy. This sterilizes the entire cells, whether it is cancer cell or normal cell. Everything becomes dead into this. We have to take special precautions so that this is hot, warm saline that we keep pouring around, because even the assistant's hand, and as a surgeon, my hand, you have to be careful that it does not freeze our fingers. This is very cold. So this kills all the cells and then we reimplant it back. We just put it back. Since the osteotomy was only single in the upper part, the lower part was well preserved, the vascularity regains from the below upwards. And we, instead of using a prosthesis, we use plates here, and once the bone heals, we remove these plates because the child is growing. Now the another method of biological reconstruction is rotation plasty. So this practice, this used to be the practice in 70s and 80s, but with the advent of implants, we stopped using this procedure. Why? One, because it looks very grotesque. You can see here, so the leg, the part of the tumor is removed, the lower part of the leg is taken up, rotated 180 degree so that the ankle faces backwards. Why it is important? Because you know the normal movements of our knee joint is backwards, it goes back in flexion. So this ankle starts acting like a knee joint on which we can use prosthesis, and these patients have excellent functional outcomes. They can sit on the floor, they can squat, they can kick start their vehicle. So this was a case where there was osteosarcoma of distal femur, and we resected the entire part. It was contaminated, so it was not possible. It was involving all the structures. So only the nerve, sciatic nerve, and the neurovascular bundle is kept intact. This is the part which was removed. And then we join part of the tibia with this femur and we attach it. So you can see here, that's the opposite leg, and this is the part where we have reconstructed with the process called rotation plasty. So in 2022, my message for tumors around the knee would be that today it's possible to do limb salvage surgery in more than 90 to 95% of our patients. The most common indication why we do amputation is where either the malignancy is contaminated, somebody curated it just thinking a benign tumor, that is the most important reason. Otherwise, these sarcoma give adequate time, they grow. It can be identified early because of pain and swelling. So unless patient has neglected it, most of the cases we can plan for a limb salvage. With the advent of prosthesis, the functional outcomes are excellent. As compared to conventional methods of orthodesis, nowadays we prefer to have mobile joints with our modular prosthesis. And in pediatric patients, we have many new techniques with expandable implants and especially the biological methods that help us to prevent amputation in this age group. Thank you very much. Thank you.
Thank you, Dr. Vivek, for a nice overview of all the tumors around the joint. Any questions from the audience? One thing I'd like to ask, when you are salvaging the knee, like a hemicondyle is being sacrificed, and you don't have cartilage at the end, so, you had used bone cement there. So how long does it survive, that bone cement?
Yes, sir. So the bone cement, usually the previous notion was that if we use, and we are talking about benign tumors where we have done curettage and we have used bone cement. So previously people used to think that if we use bone cement, it causes exothermic reactions and that damages the cartilage and leads to secondary arthritis. That's why bone grafting was used. But over the time it has been shown that if we take proper precautions, like especially during the heating phase when the cement is setting in, we need to pour cold saline over there so that the exothermic reaction is, does not damage our surface. Second, once these are kept, so far I have not revised any case, and based on my experience in Tata Memorial Hospital, Mumbai, we even never had to revise any case because the cement broke down from those places. So it may last probably 20, 25 years, 30 years.
And if it is in a young child, if he grows up into an adult, then maybe a joint replacement or a other customized prosthesis can replace if required.
Yes, sir. So another part is if it's a small child, like if a pediatric age group, and probably I'm not talking about GCT because we see them in mature patients, but in pediatric age group, I would prefer to use bone grafts more. But in adult patients, I'm more happy with bone cement.
Okay, thank you. Thank you very much.
Yes.
In plastic.
Yeah.
But in another patient, you have done this mega prosthesis. So what drives you to led to the decision that I will do mega prosthesis or I will do rotation plasty?
Yeah, so one of the most important part is, like I said, 3 important factors that determine histology. We know it's sarcoma in both the cases. Second is about the age. So age is the most important factor that helped me decide. So if the child is too small, it's not just about the age but about the anatomical bone size. So then using a mega prosthesis will fail if we use, even if we use customized. So in those situations, I prefer to use do a rotation plasty or some biological reconstruction, sterilizing the same bone and keeping it back. And affordability is a very important factor that we offer the patients, and then depending upon if they can afford, we can choose that. Yes, sir.
One question. That was an excellent presentation, Vivek. Congratulate to you.
Thank you.
Question is, in osteoarticular lesions, especially, I have read reports of sandwich technique where they have used bone graft along with bone cement, and they have used gel foam, something like gel foam in between, so that once the bone incorporates, and they can again take out the cement and add more bone graft.
Yes.
Any such experience?
Yeah, so actually this technique was very much practiced initially, and especially in Tata Memorial, where Dr. Jaipuri, he evolved and popularized it. But in our clinical practice, we have seen that once, it depends upon the amount of subchondral bone that is remaining after curettage. If we have, even if we have 2 mm of subchondral bone left, it's very safe. But once sometimes it happens that it's just the articular cartilage that is there, and it's ping pong, you can feel it that it's very soft. In those situations, we may use a layer of morselized bone graft, and to prevent the damage from the cement, we pack it up well with cement. But if you ask me, I've seen, I never use that. I prefer, even if it's just the subarticular surface, I would use bone cement, and I'm happy with the results. I've not seen failures with that.
Thank you.
Dr. Vivek?
Yes, sir.
Is there any length criteria that how much of length of the femur or tibia will you preserve when you are doing a resection? Or what is the minimum length required if you want to do a salvage? Is there any length criteria?
Sir. So normally the modular implants have some fixed sizes, like this stem which holds in the canal. So they are in the size of 10 or 12 to prevent early loosening. But when we are, and the challenge comes when we are talking about longer resections, when the bone length, amount of bone which will remain is small, or in pediatric patients where it's going to be a small length which will be there. So we prefer at least minimum 10 centimeter bone that should be preserved. Recently I did a case where in distal tibia, it was only just 6 centimeter which was remaining after tumor resection. But the entire weight on this implant for just 6 centimeter hold, I knew it would fail. So there is something called composite type of reconstruction. We combine biological along with this mechanical. So I resected the bone somewhere in between, dipped the remaining part in liquid nitrogen to preserve extra bone so that we can use the conventional stem of 10 or 12 centimeter. So first priority is to get wide margin resection. We never compromise on that. If we have to go for amputation, if we are not able to get wide margins, then it's better to go for amputation rather than thinking of doing a salvage with compromised surgical margins in cancer cases.
Thank you, sir. I would like to invite
Thank you.
VP Singh, sir, to felicitate Vivek, sir, and including the chairpersons. VP Singh, sir.
Hello. So I'm back now. Hello. I see quite new faces. Sanjeev sir has come, and Vivek. I see Vivek as well. Hello. So hope you enjoyed the surgery, live surgery. And second thing that this is an open forum. So now this time we had kept some time for practically based discussions of cases. So anybody who is interested in showing cases are most welcome, number one. In general, I have Dr. Gyan sir from Darbhanga. He would be showing some cases. We should then followed by Rishabh. Dr. Rishabh is showing some cases. And Dr. Vivek sir, yes. So they can come and have a seat on the dais and we can take it from here because we need to discuss, practically know the problems and we can sort out things. Hello. Welcome.
Thank you, sir.
May I request Sanjeev Patnaik sir to be as the chairperson, please? Dr. Sushil sir, if he is free.
Just a minute, let me do it.
So, I was saying this to Dr. Vivek, whatever would be the situation, but Dr. Ashish will always be very cool. That smiling face never goes off. Big show, Dr. Ashish. Good show. A very good evening. I'm Dr. Gyan Ranjan, currently working as head of the Department of Orthopedics, Curesta Hospital, Ranchi. And we have with us my friend.
My name is Dr. Vivek Shankar. I'm an associate professor in Department of Orthopedic at All India Institute of Medical Sciences, New Delhi. And as the case goes, this is an open house. It would be an interactive session. You can ask questions, you can answer the questions also.
Yes, so that we can share some of our knowledge. The X-ray is there on the screen. So first,
so this is a 20-year-old male patient presented with fused hip. As it says, the brochure says this is for PGs. So I'm going to ask the PGs if they are present over here, what are the things that comes to your mind when you see this X-ray?
Any of the postgraduate students sitting here, please do reply. Anything? Anything right or wrong? Please come up.
So I'm going to ask the chairperson, sir. Sir. This is a 20-year-old male presented with fused hip, ankylosing spondylitis. In the pre-operative planning, what do you think is important? Are other things important in this case?
The most important, apart from the radiology aspect, I want to see the patient clinically. Because I want to know what is the deformities, basically, what are the other joints which are involved in this case. Especially if you see ankylosing, how is the spine, what is the cervical spine is also important in this case. What other,
so
I would say,
mention that the spinopelvic,
yeah, spinopelvic as well as
parameters are very important when you plan to do a total hip replacement surgery.
Whether it's a fixed deformity, fixed flexion or a abduction, adduction, what type of deformity it is, whether we are going to do it simultaneously and what, or one at a time, and what is the position on the operating table, that is also important. So all these needs pre-operative clinical analysis.
Sir, I was coming up with that question to you. He said, will you do it in one sitting or two sittings?
That depends. Yes. That depends on the situation, what type of deformity you are presented with.
Okay.
So in this case, there was no spinopelvic deformity as per se, though the lumbar lordosis was completely obliterated, but there was a flexion deformity of the hip joint, both about 20 degree and adduction deformity, as you can see on the X-ray, about 20 degree. The hip was fused, the knee was okay in this case. So now, in this scenario, when you plan the surgery, what are the different things that you think of? Dr. Arnav?
No, Rishabh, Dr. Rishabh.
Dr. Rishabh.
Regarding planning of the surgery, as is a fused hip, we probably, regarding pre-operative planning,
yes,
pre-operative planning.
Probably which approach you will use, at
Posterior
what all implants you will take, those all things we ask.
Yeah. Priority will be, my approach will be possibly Moore's approach, which I am mainly using it. Position will be lateral.
Sir. Yes, right. Sir, please proceed. Absolutely. Harding's approach you are saying.
You can
that
add,
is the right thing what you are saying. Absolutely. Even me, what did you do, sir? In this case, how?
I would ask the
will
House first, then we
please.
will get to the
We have
other
a
part.
big
So Dr.
orthopedic
Dillo
surgeon
is
from
there.
that.
I think he can
sir.
add something to this.
Sir, please. Sir, please give.
So, this is very difficult. First, to approach from the posterior side for this hip. I do osteotomy first, dislocate, and then by piecemeal I remove the head normally. And then usually, even if it is ankylosed, we get a slight space where we can see that this is the margin between acetabulum and femoral head. Usually we...
While removing the acetabulum, you want to say?
Yes.
Okay.
That's the...
So, sir, as sir has said rightly, we will have to plan it accordingly, the patient, whether you want to do it in one setting, both the hip in one setting, or alternatively giving some time to it. Because in these cases, there would be extensive bleeding that we'll have to expect, and you have to be ready for that once you take the cut, because it's an inflammatory arthritis. Secondly, dislocation would be difficult, so we'll have to plan it that because there is a flexion deformity at the hip joint, the cut at times are difficult to take in the neck, and sometimes when you take the cut, the saw goes in through the acetabulum. So you have to be very careful when you're doing the neck cut in these cases.
But in some cases, we have to remit also. Sir, could you enlighten us with your experience, sir? Okay.
Then I think if you, as sir has suggested, then I think when you have taken out this, you can try moving the ball of the head with a corkscrew if it's possible. Otherwise, you start rimming it. And as sir said, most of the time, not 100%, but most of the time, you will get a rim of soft tissue or a rim of acetabulum margin, which will guide you towards the bottom out of the acetabulum cup. Now, placement of the cup, sir, I'm going to ask you placement of the cup. Why it is important to keep an eye on the placement of the cup, and how would you do that?
The most important here to recognize the spinopelvic deformity, whether the spine as well as the sacroiliac joint, I think it is not fused here. So that is probably mobile, yeah. So that is the one part. Now, as far as the removing the head, the resection of the head is concerned, I would prefer to remit in situ. That means I will take a piece of bone in between, the neck resection, intercalary resection I will do, and then I will remit directly. And here, the important fact, we have to have a C-arm. Intraoperative C-arm is also very essential, especially when you are not sure. Somebody rightly pointed out that there is a small amount of fat pad where you can, the pulvinar fat, where you can identify that at least you have reached the acetabular floor. And then the tal, you have to have a note that in most of the cases, the tal is still preserved. So in that will also help us in the orientation of the cup. So we try to keep the cup parallel to the tal. And then all these things pre-operatively you have to plan also. Where will be your placement of the cup, how deep, how much you can ream. All these things is the pre-operative templating is very essential in this case.
Sir, I would like to visit sometime to Bhubaneswar to see this miraculous surgery by the meticulous surgeon. Sir, only one question is, other than this, do you have any other way out? How do you take out head? Only one this way, like making osteotomy and you remit and you take out the corkscrew. Any other way out?
See, unless or until there is some movement still possible, once you try to move the limb, you see that some movement is still possible, then it's okay. Yes, then you can probably dislocate also after removing, doing the capsular release and all these things. I am a lateral surgeon, so I'll approach this through the lateral way. I am not a posterior surgeon.
Yes,
so
of course.
I think the message is that one, you should go through the approach where you are maximum trained.
Absolutely.
So I will not use any other new approach. I'll go for the lateral approach. And if need be, sometimes you may have to be prepared for a trochanteric osteotomy. Sometimes, very rare.
So as far as, pointed it rightly.
Sir.
Yes, please, sir.
For placement of the cup, usually I place femoral component trial, and then I put a trial in the acetabulum. I see the combined anteversion and everything, and then I rotate with the trial on both the sides, and I see where the cup is rightly placed. So I mark that place and then I put the cup.
Sir, so would you go with the normal anteversion when there is the hip is not fused, or would you decrease or increase the anteversion initially if you take it to the C-arm?
I don't use C-arm because I do posterior lateral approach and it's very difficult to use C-arm in that position. If you are using an anterior or anterior lateral, then you can use. But if everything is just like SI joint and spine is okay, then I go normal.
So because we are doing the first hip right now, the hip is still flexed. It is still flexed a little bit because the other limb is not mobile.
One should not go for the first time in this first hip. He should do normal hips first.
My experience says that if you don't keep the anteversion too much, generally is written that no anteversion is less anteversion. But if you don't keep the anteversion too much, if you reduce the anteversion in the first hip, then maybe you're more protected and not giving an extra anteversion because of the already flexed hip in angstpond.
I have seen anterior dislocations also sometimes. So anterior dislocations also even in normal hips, sometimes you try to prevent posterior dislocation and it occurs interior. So one should be careful in both the sides.
You ask a question?
Okay. So one question, like when we are doing both sides, particularly Patnaik sir might reply to this case, when we are doing both side THR, what do you do to, what steps and what protocols we should follow so that both sides is almost equal, the geometry of both sides becomes equal, almost, because it's very tough, I hope, to get same geometry.
The first thing I pointed out is that what is the position of the patient, because whether I can put the patient in lateral position or not. If somebody who is having abduction, bilateral abduction deformity or and flexion, it's difficult to put it on the lateral. So you have to go for an anterior approach if you are an anterior approach surgeon. In that scenario, you probably can think of doing both sides together. But in this case, these are difficult hips, so I'll never advise that one should go one at a time. But if it is not possible to do one at a time, then only you can go if you are an anterior approach surgeon. So that is one thing I think the other house will...
So we have now placed the cup. We are planning to do the stem. At this point, when you're reaming the stem, when you're broaching the stem, what one thing that you think is important? To maintain the length of the limb. Because the first limb will determine the length of the second limb, and you would like to give both the limb the same length. So while doing this case, the three things that are most important is that do not over-rim the acetabulum. In the first hip, keep the anteversion, the acetabulum on the lesser side, not on the higher side. And third, while you broach the femur, take the vertical offset, note it down, and horizontal offset, because you are going to give the same vertical and horizontal offset while doing the second limb.
So I think we can be slightly liberal with the first hip, because that will determine your second. So once you have done your first hip, you have to match it to the first. Yes. So that means you can be slightly liberal. But again, the cuts have to be absolutely at the
This,
levels.
This is the immediate post-op X-ray which we had.
The another thing I'm concerned here is to put a cemented or an uncemmented stem, because what I see here is slightly thinner cortices, wider medullary canal. So I will still have my cemented stem backup.
Yes.
Because these patients might not have walked for maybe so many years. So these could be osteoporotic in nature. So these, in this scenario, backup of cemented stem has to be there. Otherwise, you can easily fracture it.
Any question from the house?
Well, one last question, sir. One last question. Like 2 sessions, 2 hips, what should we keep in mind that the maximum geometry is like almost equal? If we are doing it in 2 sittings, so there shouldn't be much difference. So
See,
what
the most important is that you have to see the all the balance. Basically, the soft tissue balance is very essential. So I'll not leave anything lax. So it has to be absolutely all right. I don't mind if somebody has a 1 centimeter here and there discrepancy, but it should be absolutely balanced. If I am in doubt, dual mobility could be an option.
Absolutely. I think Ashish is not present here. I would have asked him the planning he would have done for this hip with the robotic surgery. This is the post-op X-ray of this case. So coming to the second case. Dr. Rishabh, what's your take on this?
This is a case of left hip protrusion with the central, the head of the femur is centrally placed. In this case, I'll be planning for 2 techniques which I can sandwich technique, a bone graft, which the head has come, I can put it and use a cage to prepare the acetabulum cup. And an extra, sir, anything? Sir.
Sir, how will take out this head? If while doing, what approach should we? Sir, we can start from the house. Our senior members are there. How to take out this head?
I don't know. I think we shouldn't take out this head and let it be there. I mean to say, just build bone, probably a cage. It will act as a bone graft. I don't think we should chase this bone out because you will have a big cavity, intrapelvic. So I don't think you should chase this bone out. I think just leave it like that.
Exactly.
And you can put a cage, and over that cage, some mosselized bone graft, and then put a cemented cup.
Sir, your take.
Take out the head, slightly freshen the lower part base, and then put the graft. I don't think there is a need of cage. You can fix the head cemented with the impacted bone grafting. You can put the cemented head with that only.
Sir, how will you proceed?
Okay, good question. So basically, this would be a problematic case because dislocation would be tough. So probably, first of all, we will open it up and the dislocation would be tough and sciatic. This must be a lady? No. No, no, in ladies, 14% of the cases, the sciatic nerve is aberrant. So one problem. So probably we'll do in situ osteotomy.
Maybe this it's a fracture.
In situ osteotomy.
Yeah.
Now second problem which we'll face in this case is taking out the head. So taking out the head, there are multiple options. First, you should try out with a simple corkscrew, but it will not come. So then you should cut it with in situ, take it out somehow. Another option is there in which you start rimming. So suddenly you start rimming and you'll find the cartilage envelope which is on the medial side, which will come this side. But you have to take out the fragments. Then you have to assess the anterior posterior column. So that has to be done and classified according to the AAOS classification. And then you have to, you can see if there is a medial defect, you have to reconstruct with a mesh if required, and then do bone grafting, take out the hip center to the the teardrop, iliopectineal line teardrop, and you have to do impaction grafting. I would do the same thing. So two things I will tell you. One, impaction grafting special method of wafers, grafts. It's been described by me and it's published in, that is published in Journal of this Asia Pacific somewhere. It's published. Singh sandwich technique, they accepted, so I am happy. So that is a good method. So I did, I think, 23 or 25 cases, 4 years follow-up. Second is...
What do you use for that between the two grafts?
See, what will happen, the medial side would be, either it will be deficient or you have to put a mesh. Then we put some graft, which is with a mill moisturized, then wafer, then again graft, then wafer. So it's like burger. So you do it like that. Yes, sir. And then you punch it. You have impactors which can be made, custom made and taken. And second thing, these types of fractures, a case of 55 neglected acetabular fracture recently got published in SICOT journal, 5 years follow-up. So in that I have very well described how do we manage all the cases. So probably I will do it like that. But what is the sir will say?
So bone stimulants, have you been using these bone stimulants which is in the market instead of graft anywhere?
The Bujibun. We are not happy. I am not happy.
That's what.
In SIO or Sancheti we had issues.
Experience with CERAMENT?
CERAMENT. No. CERAMENT means?
It's a bone substitute which gets
No.
absorbed.
No.
It get absorbed and is.
No. Here in PR, the patients are very poor. Even if you ask to get Bangalore, Ramaiah, they supply oleograph, autograph, we can't buy it. But yes, we'll get a CT scan.
You need a CT scan because you need to see this is a post-traumatic situation. So what is the columns? You have to see if there is a fibrotic union and probably you are going to remove this fibrosis and all. So I think a good pelvic acetabular surgeon can deal with it first and then in the second, because you're only 22-year-old.
No, sir. So, sir, I'll tell you, in these cases, you have to go at once. Now, once I was in Korea and I was presenting similar cases, they asked me one thing, that who does pelviacetabular in your hospitals? I said, everything in India, we do it. So I am actually doing pelviacetabular as well. So if the posterior column is deficient, you can stabilize it, fix it with in situ MATA plate or recon plate. Now you have another good option, that is the DePuy peripheral locking heads, locking screws. So I think depending on the size of cup, number of holes are there. And with that you can have the central multi-hole.
The concern is only if the CT scan shows non-union, then that is the point.
Yes.
Otherwise, I will straight away go for it, multi-hole cup with lot of screws through the, that will hold.
Yes. So, but I would be very happy this month it should be published, 55 cases like this, 5-year follow-up published in SICOT.
Yeah.
So many records are coming with you. Many records, new records are coming with you.
No records. Just keep reading.
So you don't take on bone stimulants. How do you feel? Should it be used or not?
At the age of 22, so the young patient, I don't think it should be used.
And the other ways, like the
elderly patient, probably osteoporotic bone, then definitely it should be used.
Sure. So, and now
this was done.
They're perfectly done.
So what we did is we tried to take out the head. We took the neck cut. We tried to take out the head, but because there was a bottleneck in the head, we didn't want to ream it. So we fixed it over there. We used an oversized cup over here, if you can notice, so that there is a peripheral fit, and we could come out with.
I am missing Dr. VIJAY sir from him.
Vijay
He would
sir
have told that you should have put one screw here. In the issue.
Multi-hole cup, at least 3 to 4 screws.
He would have told. He once called at Gujarat in presentation. He also told us. I remember. Vapi. Yes, sir.
So we're going to get one last case.
Hey, keep on going. No tensions, please.
Ashish.
We should ask anybody from the audience. Yes. See, I have PGs here.
Please, young guys, please say, please pick something.
This tallest guy in this
See, I don't want to call your names from here, please. I don't want to make this a lecture theatre. Request you all, please stand up and say something.
Say something.
So you can tell the clinical history of the patient. How old is the patient?
Okay, so this is about 45-year-old patient. He had presented with this X-ray. He had had history of trauma about 6 years back. And this is the X-ray that we have got. And there was some pus discharge present when he was presented around the incision, previous incision. He had a history of multiple operation about 3 times. So this is it.
So this is a case of like neglected neck of femur fracture, neck of femur plus shaft of femur fracture most probably. So it's a case of neglected neck femur and with presents with discharging sinus. So in the starting I will go for like AP X-rays there and normal blood parameters I will go for them. And my approach to the operative approach to this patient would be most likely the removal of the implant, that screw and the nail, followed by application of cement spacer in between. I will check active infection is not there or not, and followed by debridement. I will initially go for a cement spacer, like we can put it inside, like in the shape of an implant, with removal of that head. That would be my initial approach.
Very wonderful answer. Seriously, you have answered it right. Just I want to know, do you know how to make that cement spacer? Please elaborate, because that would be very comfortable to the public.
Actually, I have never seen that, but I have seen, we get a template of that actually. The shape of that implant, we get template and we can put it the...
Sorry, he's our PG. So what do? We have cemented molds available, PHR molds. So we fill it and we take it out and put it there. So I use articulating spacers for knee, and one patient is there having 90-day garland and Zimmer, Alakos.
You can use it.
At the end, I will show you my style, how I work with the poor people.
So intraoperatively, that's your intraoperatively thing. But I'm most interested in the pre-operative planning, which is, I think, is most important in this case. So before you decide or plan out any surgery, what is one thing that you want to rule out?
Any active infection, that is more important.
But you said that discharging sinus. I said I will go for the blood reports initially, that CBC, SR, CRP, the total count and all.
Sir, would you do any aspiration and go for any culture before we, take up this for surgery?
Actually, the patient already must have got a lot of doses of antibiotics. Mostly the culture reports come as no growth only. So that is a problematic thing every time, because already a lot of antibiotics they have taken.
That if the patient is taking antibiotic and you want to do it, would you stop the antibiotic for 2 weeks or and then do an aspiration again and then decide upon whether to use what kind of antibiotic during the intraoperative and postoperative period?
Yeah, sure. I will do it.
Good, great. Nice.
Now,
so Dr. Vikas Anand from Dhanbad, your take, the giant arthroplasty surgeon, please speak. Welcome to AMC.
Thank you, Dr. Gyan. So I will do exactly the same as told previously by my colleague. We will first rule out the infection by clinically and by pathological test, and we will do if patient is taking antibiotic, then we will put off for him for 2 weeks at least, and then we will go for aspiration, and if we intraoperatively we also get aspirate from all around the tissue from synovial, and then go for culture and sensitivity. And we will put antibiotic cementing spacer. And
so the house is now decided that this is 2-stage surgery.
Yes.
Is it?
I think it is good to do a 2-stage surgery. first, if it is possible, to stop the antibiotic for at least a couple of weeks, and so that something grows, you know that it's whether a gram-positive or a negative infection or anaerobic culture. All cultures have to be done. If it is you can do aspiration, it is okay. But if the patient has already taken a lot of antibiotics, there is no point in aspirating it. The question is, we have to immediately give stability to the patient. So our goal is, you have to remove all the implants, take intraoperative cultures, and then if something grows from that, give adequate IV antibiotic, give a cement spacer. The question is whether you want to retain that head or not. You have to remove the head, because we have to give a spacer which will incorporate both the acetabulum and the intramedullary femur. So it will be a spacer, and then probably in 6 weeks' time, you can revisit that. If everything, again the aspiration and all the blood parameters are normal, then you can go for a second surgery. And that will be most probably a total hip.
Okay. So what we got done is, we got an ultrasound in this patient done, and we found that there was a very superficial pocket where the pus was coming out. We got an bone scan done to look for the vascularity of the head, and we found that the head is not vascular. So there was no point in retaining this head during the first or second procedure. Now, we gave the antibiotic for about 2 weeks after getting a culture done, which came positive. And then there was no discharge present for about 4 weeks, with a sequential ESR and CRP was within normal limits. So, but the X-ray looks exactly same now. Now, do you think we should go and do a 1-stage surgery or 2-stage surgery? Sir, from you. Sir.
Always I will prefer to go first. I will take out everything, debride it, clean it thoroughly, nicely, and according to the culture, we will put our patients on antibiotic and wait for 6 weeks, and then plan for reconstruction surgery.
So
the
patient has already no discharge, ESR, CRP within normal limits for 4 weeks.
For 4 weeks at least.
Yes.
And then we can go for surgery.
We can go for surgery.
Go for surgery.
Right. So
the implant in, it's a foreign body after all.
Implant
So
yes.
even if the culture or everything is negative, but still you haven't removed the implant.
We have not removed
So
the
implant itself.
And if the implant is there, the biofilm would be there.
Yeah,
which
biofilm
would be,
is there, and
which would be avascular, and it would be full with all the kind of bacterial or culture positive things. So a thorough debridement would definitely be required. So now how would you approach the case? We are going to do a surgery tomorrow morning.
So that means all the implants have been out. And
No, we're going to do a surgery tomorrow morning. Pre-op planning today.
No, 2-stage surgery for me. The implant will come out, thorough debridement, antibiotic-loaded cement spacer, and probably I have to go slightly deeper, so maybe a longer stem, antibiotic-coated, will be better. And then probably also in the soft tissue, I can use stimulan, along with that antibiotic-loaded stimulan pellets. That will give additional support. But most important is culture, that you have to know the organism.
Absolutely.
If you know the organism and the appropriate antibiotic, and I think within 6 weeks you can do the 2nd-stage surgery.
You agree with, everybody agree with that? Yes. Apart from sir was for first 1-stage surgery, because the culture was negative. There was no discharge for 4 weeks, and ER-CRP was within normal limits. Sequentially, ER-CRP was within normal limits. So sir is for 1-stage surgery, just as for 2-stage surgery. Right. So we did this. Any comments, sir?
Looks okay to me.
So maybe I got lucky with this case. We got out with this case primarily because there was no light lesion which was there when we were doing the debridement, and we could take the implant out completely. As I said, there was the culture and sensitivity was negative for 4 weeks. There was no discharge. The ESR CRP was sequentially within normal limits, and so we planned out a 2-stage surgery, keeping in mind that if we do not find any active pus in the during the intraoperative finding, we would go and do a first-stage surgery. So the beginner's luck, but
one question I'll ask. Sir, if there is no infection and a failed PFN, how would you go for 1-stage or 2-stage surgery? With a failed PFN, if there is no infection, that would be a 1-stage or 2-stage surgery? That will be 1-stage.
So, but in this case, because there was a sinus, you can never be sure. Even if it is, you can have a sinus again after say 1 year or 2 years.
So I'm going to give you, I'm going to show, sir, I'm going to show you the pre-op X-ray right now, and I'm going to show you the post-op X-ray right now. Did we miss something? So for the PG, this was for the PGs. Yes, this for the PGs. Whenever you see an X-ray, you have to get an X-ray of the lower and the upper joint. Otherwise, you're definitely going to miss something. In this case, we did not miss it. We knew it, but for the PGs, there was a fracture in the distal end of the femur, which was united. But we needed to know the extent of the fracture, and accordingly, we have to adjust the length of the stem.
Just 2-3 photos, which the doubt always comes to me. I'll just 3-4 minutes, not more than that. Please do guide me because I never got answers to these questions. While I was working in Bokaro Steel City, one day a nursing home called me for an old patient. That old man was very weak, grossly he was very weak and thin, and they were very poor. And I went there, he had 2 daughters, and they told me, could I do something for him? And this was his situation. Will it come? Can you start it? Yeah. So, looking at him, his general condition was very poor, and I don't know why it's not coming. Coming. It might take some time. It's okay. Carry on. So I tried. I gave him dressing for 2-3 days, but I had no answer to this. I always take this photo whenever I go to any conference, and I ask this, what could I have done? Anyway, I think that patient never came to the hospital again. I just thought he might have died because that was a bilateral fracture, and they don't have money for the treatment. But in normal case, if we encounter anything like this, how should we proceed? I have few more things, photos of this. This is the X-ray. I'll come to this. Sir, I'll surely, I'm just showing you a few things what I have. Yes, sir. Thanks. That answer I got from Dr. Sarnendu Samanta also. Yeah. And he told me the same thing while I was showing this in AOTS. But I carry this and I get the same reply to all plastic surgeons. Anyway, I never had the follow-up of this patient because after 5-6 days, I don't know whether he died or whatever happened, they were not having money and nursing home didn't keep him. Just, can I have another?
So on a lighter note, I would say that I will take Dr. Gyan's number and refer the patient to him.
Which one?
He has more experience in this than I do.
MC. I like to go like from post-op X-ray. I'll go back in this. This, he's an old man, 75-year-old around, having cardiac problems. His ejection fraction was 35%. He was in acute renal failure. He had some renal problem, not in failure, but he was on medication. And he had a failed DHS non-infected. After like he went for a neck of femur surgery, someone and DHS, and then he came to me, and I tried, and this is my post-operative X-ray. Any eventful thing which could have happened during surgery. Why I put this SS wire inside? Okay.
Could be a periprosthetic fracture. That
I did it, sir.
Yeah.
Actually, intra. What happened? While taking out the DHS, one screw like broke inside. I thought I could rim this and put that screw in the canal. While doing that, it got fractured. Then I had to open it again. Just now I can start it from here. This was the shortening present, and we started the surgery. Everything was going good, and we thought we were rimming the canal, and we thought like we are ready for it. And suddenly, my assistant told me this, ki, sir, I don't feel it comfortable. Hemda has experience of around 35 years, and I said he told, and then I said bring in the Singh arm, and I saw that I have breached the cortex. Because I just thought if I take out the broken implant, other thing, I can put that broken part inside the canal. But it broke the cortex, and then finally we have to enlarge our incision, make the incision larger, take that SS wire, folded it, then we gave the trial one inside, and then when the trial one was fixed, we took it out, gave the cement, and we really had very little time. So everything was very fast. And finally, it happened like this. Still, that screw is inside, but I don't think it's not coming in this. Might be behind posterior somewhere.
if there is a periprosthetic fracture, do you think only the wires will suffice, or you could have put a plate to augment that?
Sir, absolutely, sir. I could have plate. I should have put a plate.
You may not be prepared.
I was not prepared for it. I should have put the plate. That would always be a better option. And but I never had that plate, and I was working in a not small hospital. It was not a big corporate hospital. Yeah. So like where I could get everything
Actually,
on time.
I would just tell one similar case in which I was trying to do a intertrochanteric fracture, a very comminuted intertrochanteric fracture, where I was trying to put a uncemented stem. From Smith and Nephew, that uncemented stem. I was. The only problem was that with the last impaction, there was a crack. So I could feel that I had made some defect. So immediately the CM picked up that there was a fracture. So I waited there in the OT for the next 1 or 2 hours and ordered a plate and then put a distal locking LCP and bypassing it with screws as well as wires. So because we cannot do a half-hearted thing, I know that I have created an intra-articular fracture there, just at the tip of the stem. And I was trying to give uncemented. So the problem with these company people are that sometimes they don't have all the sizes, and you have to be accommodative to them. And for that, I have to put one size bigger. I was not very comfortable. But with the help of C-arm, I was trying to hammer it, seeing the C-arm picture so that I don't fracture it, but ultimately I fractured it. So I waited in the OT for almost 1.5 to 2 hours. Plate had to be autoclaved and everything, and then fixed it.
So this is a 75-year-old
Otherwise,
patient.
you could have done a two-stage.
According to this is a 75-year-old patient with a CKD with a, there is cardiac ailment. So would you have thought of some other implant in this case?
I think, see, you had a failed DHS.
Yes, sir.
Yeah.
That's what the screw broke in while taking out the third screw broke. That was a failed DHS done around.
So most of the CKD patients, the bones are osteoporotic. So in this scenario, I do not prefer the uncemented stems normally. And because I have to bypass that fracture site, so I'll put a long stem. So I think you have correctly done that long cemented stem. The only thing I'll be concerned is while reaming. Because elderly people, if you are not reaming in appropriate direction, and you can also use the C-arm intraoperatively to see whether you are directly in the canal, because the reaming is also very essential. Because if, and the stems look slightly varus, there is some varus element in that stem, if you see the previous X-ray. And those things, because you have to also encompass that there is some amount of femoral bowing which occurs in the elderly, the femoral bowing. So once you are putting these type of straight stems, sometimes they hit either anteriorly or possibly, because you have to be careful, because they don't have that same anatomical angle just like your femoral nail. You get those in the uncemented stems nowadays with anatomical stem. But the cemented stem, they are usually the exeter type, they are all straight. So you can very well hit the anterior cortex. So that you have to be careful, use the C-arm both laterally as well as AP and lateral views. Yes. So that could also, especially during reaming, because soft bone, CKD patient, usually soft bone. So very careful during reaming. That probably could have saved.
Thank you, sir. That's just one last question for Ashish. Would you consider a bipolar in this case, cemented bipolar? Just one last question.
Absolutely.
Thank you. Thank you very much, sir.
Thank you. Thank you, sir.
Thank you.
So we end the session here. I would like to first felicitate my friend, good friend. Actually, we came out to see school friend to see DDLJ, I think, together roaming out. We came out to schools and Michaels. So may I request Dr. Prakash Dhillon sir to please felicitate. Dr. Vivek is faculty at AIMS. इधर बीच में नहीं मैं नहीं आ रहा थैंक यू May I request Sir Prakash sir to kindly felicitate Dr. Sanjeev sir for chairing the session, and please come sir. Small token of photograph while you being on the stage. You're welcome. May I request Dr. Sushil Singh sir. Thank you sir. And Dr. Rishabh, please. Thank you. So I thank you, Dhillon sir, for thank you. One more. May I request, sir, this way, sir. Yes, sir. Sir, with this, I officially close this day. We are on 5:17, right on time, I believe. Now we need 2 hours time to set up the hall for a gala musical evening. I welcome you all for the grand gala party dinner, and we'll be having music the music and snacks this side, and dinner will be in Kesaria Hall. So I request everybody to kindly be here by 7:30ish, 8. And tomorrow again we'll have Sorbonne session on the robot. 9 to 10, and 10 to 11, Dr. Adarsh and myself will be demonstrating a live Mako robotic surgery. In the afternoon, we again have a robotic surgery which is being beamed from Calcutta. That would be a Merrill Cubis robotic system to understand the basic differences, and a person speaking on the Cubis system. And then we'll shift over to the revision scenarios. So thanks a lot for making this day a grand day. And I hope you enjoyed, and I'm thankful to each and everyone for sparing your valuable time, coming and sitting here for the whole day, listening to things. Thank you, sir. He'll say something.
Just one thing, I want to welcome you all at Hajipur on 9th, 10th, and 11th. The state conference, BOACON 2022, we are conducting this time in Hajipur by Vaishali Orthopedic Society. My friend Pankaj Kishore is not here, just they called me up, And I hope few people are there from Vaishali Orthopedic Society here. Please come and participate. That would be a nice program. Thank you all for patience hearing. Thank you, chairpersons.